need to pull this down, Joelle, or they can see me?
Yeah.
Okay. I meant the PowerPoint presentation.
No, they can see.
Okay, righty. Good morning. Welcome to the August 18th, 2016 Public Health Nursing ITV. My name is Joy Hoskins. I'm the Chief Nursing Officer for the Department of Public Health, and I'm so glad you could join us today. We've got a very full agenda. I think someone may have their mic open. If you wouldn't mind to check that for us, please. Thank you. We've got a full agenda, and we'll go ahead and get started. I'll ask Luann to go ahead and come on up. If you wouldn't mind, if you do have other sites or participants that join the ITV, if you could please check your mic and make sure it's closed at this time so we won't have any of the background noises or distraction. This ITV is being taped and will be available for archived review in the next few days. So thanks again for joining us. Luann Cottrell from the Maternal and Child Health Division is here today for our nursing CE. Thank you, Luann, for being here with us. Luann has a long background, a strong background in public health nursing. She came to the Maternal and Child Health Division from the Louisville Metro Public Health and Wellness local health department. So we're glad to have you here today, and I'll turn it over to you. Let me get you set up here. There you go.
Okay, thank you. Joy said, I'm Luann Cottrell, and I'm with the Maternal and Child Health Division. I'm your child fatality, infant mortality coordinator, and I'm going to talk to you today about safe sleep for infants, and we refer to ourselves as Safe Sleep Kentucky. This is a snapshot of our webpage when you open it up, and we can be found at safesleepky.org, safesleepky.gov, and safesleepky.com. So we tried to cover the bases so that if you went to us and had those last three wrong, you would still find us. So a lot of people don't know that babies die unexpectedly in their sleep at a much higher rate than people might think. In the United States, about 1 in 7 deaths will occur unexpectedly during sleep. In Kentucky, like so many other things, we don't do quite so well. It's 1 in 5 infant deaths. And what we're going to talk today about is a lot of things that people should know about preventing these deaths, because most of these sleep-related deaths are preventable. An infant death, just to cover some background, is defined as a baby who dies before their first birthday. From birth to 1 month of age, the main cause is prematurity-related conditions. And this side says birth defects, but as we've been pulling the data for our annual report, what we have found is that sleep-related deaths has now surpassed birth defects and rate of occurrence, and is approaching quite rapidly, unfortunately, the prematurity-related conditions. The main cause of death, sudden unexplained infant death, a lot of people know it as SIDS. We are trying to step away from that terminology because SIDS was a catch-all for a long time, and now we know more about it, and sudden unexpected infant deaths, or SUDI deaths, are becoming easier to determine the actual cause, because we are doing thorough investigation after the baby has died. Usually the babies do not appear to be ill before it occurs. And one of the things that we're finding is that a high number of these babies have sleep hazards that are causing asphyxiation, layovers, and so on. So in Kentucky, about every 5 days, we lose another baby in our sleep. More Kentucky babies die from sudden unexpected infant death than from motor vehicle accidents, lung disease, complications of birth, heart disease, infection. This is how serious this problem is becoming. And African American babies, like so many other things, both in Kentucky and across the nation, are twice as likely to die from sudden unexpected death than Caucasian babies. Out of the sudden unexpected infant deaths, 9 out of 10 of these deaths have documented at least one known hazard in the baby's sleeping area. Those hazards include sleeping on a surface that's not designed for an infant, such as an adult bed or a sofa, sleeping with somebody else, not being put to sleep on their back, soft bedding, toys, bumper pads, those kinds of things, and sharing a sleep surface with someone who has been using alcohol, drugs, or nicotine. We refer to these hazards as risk factors because the studies have shown that they increase the risk that the baby could die in their sleep. And these deaths are all potentially preventable if people followed safe sleep guidelines. So SIDS, or that we knew of, is just one kind of sudden and unexpected death, and that number of the total SUID deaths is dropping every year. An infant death is only called SIDS if you can rule out every other potential cause. And that's from a full investigation by your coroner, an autopsy, and getting the past medical history as well. So researchers believe that 3 things have to occur for an infant to actually die of SIDS. You have to have a vulnerable infant, genetic conditions, problems regulating breathing or heart rate. And if you think about a newborn, most newborns, especially in those first couple of months, can be considered vulnerable because if they were premature, if they were low birth weight, they're still learning to regulate their systems. So you have to have that. You have to have a critical development period. The first 6 months of life period are a critical development period. Babies grow more in that first 6 months to a year than they do any other time in their life. And then you have to have an outside stressor, something blocking the baby's airway, bed sharing, secondhand smoke, overheating. So by eliminating the outside stressors, you've cut one of those 3 pieces out and you can save a baby's life. Back in 1994, the first national effort was put together to reduce SIDS, and they created the Back to Sleep program. And they recommended that all babies were placed on their back in a crib, and we were able to reduce the risk of SIDS by those measures only by 50%. Back sleeping is the single most important thing that a caregiver can do. Stomach sleeping, anywhere from a 2 to 13 times risk for SIDS. So this shows you, you can see in 1994 where the paths start to cross. As more and more people put their babies on their back, our rate of SIDS went down. Unfortunately, we have plateaued, and so now it's really time to step it up and do other things to get these babies in safe sleep environments. So it's not enough, and we need to do more. Parents that have been asked will tell you that between 13% and 25% of babies still sleep on their tummies. And this is self-reporting, so you have to take it with a grain of salt, because there are people who know that babies shouldn't sleep on their tummies, but still do it, so they may not report accurately. Our sudden death rates are still twice as high among Black infants. Use of the family bed is now increasing again. And over 70% of parents have shared the bed with their baby at least one time. And once they do it once, they're more likely to do it again. So, stomach or side sleep? Research shows that there's a 5 times greater risk if the baby is put to sleep on their tummy without anything else present. And almost 1 in 4 babies in Kentucky are still put to sleep on their tummies, and this increases the risk. People get concerned about choking. This is the #1 thing we hear with babies about being on their bellies. Because we were all told, I know when my first child was born, that you put them on their tummy so if they spit up during the night it would just roll out and they wouldn't choke. Well, research has shown that there's really no evidence that choking is more common on healthy infants who sleep on their back. And if you look at the anatomy, you can see where if a baby is placed on their back, their trachea or windpipe is over top of their esophagus. So if they do spit up, it has to kind of defeat gravity and go up and over. Whereas if they're on their stomach, the esophagus is over top of the trachea, so if they spit up, it can just fall back into the trachea very easily. The next question we get is, well, what if I do put them on their back but they roll over? If the infant can roll from back to front and front to back, they are okay, you can leave them. That usually will start to happen between 4 and 6 months of age. If a baby does it but not consistently, or they're getting like 3/4 of the way over, you can gently roll them back onto their back. But the most important thing is that they start sleep on their back every time. When an infant is rolling back and forth, you can leave them where they are. You should still put them in on their back, but if they roll over, they're more likely to roll over 2 or 3 times a night at least, just like you and I do. So the next hazard that we're going to discuss is sleep surfaces. The best surface for a baby to sleep on is a firm sleep surface, such as a mattress that is in a safety-approved crib, bassinet, play yard, any of those things. They should have a fitted sheet on it that is snug, and I say snug because we shouldn't be taking sheets that are meant for larger beds and wrapping them around. It needs to be a sheet that is meant for that mattress. And there should be no more than 2 fingers width between the mattress and the crib. Babies should not sleep on soft surfaces such as an adult mattress. And I've had lots of parents and others say to me, well, my bed's a nice firm bed. I don't like soft beds. But it's not the same kind of firmness that is in a crib mattress. There should be no pillows, no blankets, no bumper pads, no quilts, no soft toys, all those stuffed animals. I know one of the popular things right now is the little tiny blankets that can be little, like snuggled up. None of that should be in a baby's bed. An adult bed is just never a safe place to sleep. We have too much stuff in our beds. Adults, we all like our pillows and our blankets and all of that kind of thing in this country. And any of those items, including the adult's body, your arm, your you roll over and you don't realize, and you've got your stomach or your chest up against that baby, and they can become wedged and or have overlay and suffocate from that. A couch or sofa, chair, I hear parents all the time talk about, why sit in a recliner and hold the baby because that's the only way they'll sleep. That's really dangerous because when you nod off, that baby can slide down out of the crook of your arm and get wedged, and we have seen it where they'll get wedged in between the chair and your body. On the couch, it's the same thing. They can roll, if they roll over towards the back of that couch, the backs of our couches are, nice and soft and plushy, and they can, again, suffocate. Car seats, swings, and bouncy seats. I know 30 years ago when I had my first, those were all fine things for a baby to sleep in. They're really not. If you are not in a moving car, you should not leave your sleeping baby in a car seat. They should be removed, placed on their back, in their own crib or play yard, whatever you're using. And sleeping babies should not be left in swings or bouncy seats. They need to be on their back, and on their back means flat, not propped up at an angle. So soft and loose bedding. This first picture shows what a safe sleep space should look like. The second one, it has and this is how our children used to sleep. We had bumper pads, we had blankets, we had stuffed toys in there. You could hardly see the baby for the bed. Though that is very dangerous situation. Baby's breathing can be really easily blocked. Their nose and mouth do not have to be completely shut off. Suffocation with soft bedding can occur just because it's close enough that they're rebreathing the carbon dioxide that they're exhaling, and they can suffocate because of that. They can also become wedged or entrapped. And that carbon dioxide buildup is toxic for an infant. You know how it is if you wake up and you've pulled the covers over your head, or you've put on like a ski mask kind of thing to go out in the cold, and it's not comfortable, and those little babies can die very quickly. So research has shown that there's a 5 times risk for SIDS if the baby is placed to sleep with the soft bedding. And if they are placed to sleep on their stomach with soft bedding in the crib, there's a 21 times increase in the risk.
Someone has their mic open. Would you mind to check your mics, please? We can hear you talking. Thank you so much.
So the next hazard we're going to talk about is sharing the same sleep surface. Some people refer to this as bed sharing. We are trying to not use, or some people refer to this as co-sleeping, and we're trying not to use that term anymore. Co-sleeping means that you are sleeping in close proximity, and that can mean 2 things. Number 1, that you are room sharing. Room sharing is recommended for the first 6 months of life. That you put the crib, bassinet, whatever you're using, in the parent's bedroom so that they are close by. It makes it easier for feedings during the night, but they are in their own safe sleep space. Bed sharing is where the baby is brought into the bed, the couch, the recliner, whatever, and that is just not safe at all. So any form of sharing the same sleep safe surface can be hazardous for your health, or for the babies. It puts them at an increased risk for death. And that danger occurs especially with these situations. They shouldn't be sharing an adult bed at all, but definitely not with more than one person. The risk goes up even more if mom and dad, or mom and anyone else is in that bed. The sleep surface is a couch or a sofa. Even our, some of our not so prominent folks who would like to tell you that co-sleeping is a good thing will tell you that couches and sofas are not safe at all. There should not be any other children in the bed, and that includes a twin. Yes, it's real tempting. Maybe you didn't know you were having twins. You come home, you put them in the same crib together because they've been in the uterus together. They should sleep close together, but they should not be in the same crib. And there should not be any pets allowed to be in the bed. So we want you to stay close, but sleep apart. And this is one of the slides from our website. So in spite of the Back to Sleep national campaign that we talked about, we have found from 1984 to 2004 that infant death rates due to unsafe sleep hazards causing accidental suffocation have quadrupled. And many of these deaths were potentially preventable if the baby slept alone on their backs in a crib. And I know people get tired of me saying that, but that is the best place. 64% of the SUID or sleep-related cases were sharing a sleep surface, and this is nationally, and 70% were on a surface not intended for infant sleep, such as an adult bed or a couch. So when you multiply the hazards, you're going to multiply your risk. Comparing a low-risk infant who's sleeping in their own crib to infants sleeping with an adult on the same bed or sleeps.
Thank you very much.
Spring River, your mic is on.
So infants who sleep on a sofa or a chair or other surface not designed for an infant's sleep with an adult are 18 times at the risk of dying from SIDS than those infants who do not share a sleep surface. So we're going to talk a little bit about breastfeeding and bed sharing. Multiple studies over the years have found a 45% reduction in the risk for babies who are breastfed. And that's wonderful. We actually tout that breastfeeding is a good thing. However, another study has found that those infants who breastfeed and bed share actually have a 3 times greater chance of SIDS than breastfed infants who sleep in safe sleep environments. So you kind of negate by your breastfeeding, and that's a good thing, but then when you bed share, it kind of negates that benefit. And some will say that it actually increases the risk. It is safe and healthy for a mother to breastfeed with her baby in bed as long as she does not bed share. So at 2 in the morning when baby wakes up and wants fed, pull them into bed. They can be nursed in bed, but as soon as they're done feeding, the baby should be put back in their own safe sleep space. Impaired caregivers, sorry, my tongue's not working this morning. Impaired caregivers present a clear danger to an infant's well-being, and I think most people would agree with this. Drinking, drug use, including pain medication. That mom who had a C-section who comes home on a narcotic because of the C-section, she needs to realize that that medication, even though it's legitimately prescribed, can impair her ability to keep an infant safe. Smoking by a caregiver also increases the risk of SIDS for babies. And that includes smoking that, I have moms tell me all the time, well, I don't smoke in the house, I smoke outside. I don't let anybody smoke in the house. But you go outside and you smoke, and then you come in and people don't wash their hands, they don't wash their face, and the first thing they do is pick up that baby and snuggle all over them and kiss all over their face and stuff, and then they are absorbing all of that tertiary nicotine. So during these times when you're taking pain medication, or you may be having a glass of wine with dinner, maybe you're having a party at your house, it's essential at these times to make sure that their baby is in their safe sleep space, which means, again, alone, on their back, and in a clear, clean crib. Friends and family, anybody who is going to be at your house or take care of your baby needs to know the ABCs of safe sleep to assure that your baby is kept safe. Caregivers with impaired judgment can lead to putting the baby in the adult bed, to leaving them in a car seat, anything like that. And if research has actually shown, we talked about nicotine, nicotine combined with alcohol can increase the risk by 10 to 15 times, especially if they share sleep surface with their baby. And when comparing low-risk infants sleeping in their own cribs to infants who were put in bed with an impaired caregiver, the alcohol who consume more than 2 units of alcohol. 2 units of alcohol would be 2 cans of beer, 2 4-ounce glasses of wine, 1 shot of hard liquor is considered a unit. Most people who are going out to party for the night or whatnot, that is the bare minimum that they would have, if not more. And when you combine smoking with it, If their infant is smoking next to an adult who has, if the baby is sleeping next to an adult who has smoked, the infant's risk is it's quadrupled. So smoking in SIDS. Infants whose mothers smoke during or after pregnancy are at an overall greater risk. Infants born to mothers who smoked are twice as likely to die of SIDS. And their exposure to passive smoke in the household doubles a baby's risk. So there should be, and we talk about no smoking in the household, there should also be no smoking in the car, especially if you and the baby are in the car for lengthy periods of time. Smoking with the window down does not help. You still have all of that in the car. So in this state, we have a child fatality and near fatality external review panel. This panel in 2014 reviewed 22 deaths that occurred during the fiscal year of 2013. Unsafe sleep practices were identified in 9 of those cases, and 7 of those 9 cases involved sharing the same sleep surface. And 5 out of those 7 involved an impaired caregiver who was sharing a better couch with the infant. So they asked for or recommended that the Department for Public Health come up with a plan to educate the general public. So we started with the American Academy of Pediatrics and looked at their safe sleep recommendations. So the baby should be in the same room, but never in the same bed, couch, and so on. Soft objects, loose bedding, those kinds of things should not be in the bed. And you need to keep the baby away from smokers and places where babies smoke, or where people smoke. Baby should be on their back. A pacifier can be offered at nap time and bedtime. There are some studies that show that a pacifier can actually reduce the risk of SIDS. But if that pacifier falls out while they're asleep, you shouldn't be trying to jam it back in their mouth. If it falls out, leave it out. The baby should be on a firm, safe sleep surface. And we recommend breastfeeding for as much and as long as you can, but always put the baby back in their own crib. So this picture denotes what a safe sleep space is. The baby is alone, they're on their back, and that should be for every sleep time, naps and nighttime. They're in a clean, clear crib. There's nothing in this crib except for the fitted sheet, no bumper pads, no pillows. The only thing that belongs in baby's crib is the baby. So I have people ask, can the baby ever be placed on their tummy? Absolutely. Infants need tummy time when they're awake and someone is watching them. When they are on their belly, that's when they learn to use those arm muscles to push up. They can hold their heads up and look from side to side. They really need that tummy time to strengthen the muscles in the shoulders and the neck and in their arms. And that should be offered 2-3 times each day when the baby is awake and somebody is watching them. We tell you that that can happen from the time you come home from the hospital. When you first come home with the hospital with that 2-day-old, it might be that tummy time is laying on their tummy across your lap for maybe 5 minutes. Just getting them used to that position, but they should never be left alone on their bellies. So what can we all do? There are scores of parents out there who will say, it will never happen to me. I'm a better parent than that. Y'all don't know what you're talking about. You know, my mom told me that I slept on my tummy and I was just fine. So one of the things we need to do is educate not just the parents, but all other caretakers, grandparents, babysitters, neighbors. Anybody who might lay your baby down to sleep needs to know that they need to be on their back, alone in their crib, and nothing else in it. Teach others what you have learned. It's great if mom and dad are following all the things, but if grandma watches them so mom and dad can go out for their first night out in a couple of months, And Grandma does what she did with every one of her kids. She lays them on their belly. She lays them on the couch beside her on the belly, which is really dangerous too. So it's real important to get that information. If you have parents who are going to be putting their infant in child care, parents need to ask, where will my baby sleep? Does every kiddo have their own crib in this? Is the mattress firm? For mattresses that are not brand new, the best way is to take your hand flat, push it down on the mattress, and see how much give there is to it. And if you can leave a handprint in that mattress, it's become too soft over time and needs to be replaced. The crib should be empty except for the fitted sheet. Ask about their sleep policy for infants. Are they required to be putting these kids on their back? Are they required to be in their crib for all sleep times? There are many child care centers these days who will not allow parents to bring blankets into them. They will request that you either bring a sleep sack or a onesie, something, so if they need an extra layer for warmth, that they have it. But in addition, on the other side of it, you should let them know that you don't want any blankets in that crib space. It takes both of you, and you may have, as a parent, you may have to educate the child care as well. In the community, what can we do? Any agency who keep infants should have practices to follow the ABCs. You can help your community develop a Cribs for Kids program. That program can provide inexpensive play yards for families in need of a crib, so you can work with partners, people like the Kiwanis, the JCs, the Ruritans, any kind of social service type agency, churches, all of those kind of places. And help your local hospitals if they haven't done it already, and we're getting better about this every day. When I first started doing this, there were hospitals that said, yeah, we educate all of our parents, and we said, well, let us see how you educate them. And on the discharge instructions, there was a checkbox that said, talk to parent about safe sleep. That doesn't tell me what you talked to them about. Did you hand them a pamphlet as they were getting discharged with that big packet of other stuff? I know from personal experience that 90% of that stuff goes in file 13 when they get home because it's overloaded information. And hospitals need to ascertain if the family even has a crib or other appropriate safe sleep space. And if not, they need to contact social services and help them find one before they go home. So this is the next thing that gets brought up with sleep, is what about swaddling? We do not routinely recommend swaddling. However, if you are going to swaddle, you should stop by about the time they hit 2 months of age. At 2 months, they start to do the rolling. They may get up on their side. We just don't, and if they get up on their side or they flip over by accident that first time, if their hands are all bundled down in here, they have no way to push up and get out of that dangerous situation. Swaddled infants should only be placed on their back to sleep, and you need to know the correct way to swaddle. When you swaddle a baby, it should be snug at the arms, but it needs to be loose at the hips, or you can cause hip dysplasia. And you need to regularly monitor your swaddled infant to make sure that they haven't rolled over or overheated. That is one thing that we love to do, is overheat our babies because we're so afraid they're going to get cold. Infants should never be swaddled after 2 months of age because they need their arms and they need to be able to learn to roll over. Swaddled infants should never be placed on their tummies, and if you don't know how to swaddle an infant properly, you shouldn't be doing it. A sleep sack, which was what that baby was in the crib, is highly recommended in exchange for that. It gives them an extra layer of warmth. You can actually buy sleep sacks that have like a Velcro swaddle, and those are nice because even as the baby gets older, you can just have the arms out and you can still swaddle, so they've still got a little snug, secure feeling across their chest. One of the things that Dr. Goodstein with Cribs for Kids recommends, that if you see an advertisement with an unsafe sleep message or image, that you should contact the company through their PR department or website contact. You need to be polite about identifying the problem, because if you rant and rave at them, they're going to write you off as one of those crazy people that called today. You can provide information to them on sleep-related deaths. Johnson & Johnson is one of the companies who there was a real big national effort to get them to quit showing their diaper commercials, their baby bath commercials, where they would show the infants on their tummies with the bumper pads and looking all snug and cozy. And so there was so much push, and they were shown how you can still make that baby look comfy and cozy without being in an unsafe sleep. And one thing people will say is those Ann Getty pictures that are so cute, they're adorable. People have to remember that there's probably a half a dozen adults standing there right beside the baby when those cute little pictures are being taken. But because those pictures are out there and they're on walls and they're everywhere, people think that it's okay to do all those things. So you have to, you really have to put things in perspective. So this is our website, one of the things that you'll say. And as you can see, we've added a D for danger, because in Kentucky, when we found that the number of impaired adults that were watching infants and having problems with them was such an issue, we felt that that needed to be pulled out for us as well. So some of our materials, like this particular flyer, was adapted from the national site, and what they allowed us to do was co-brand it, basically. So you'll see their logo on it as well as our logo, and it's identical other than we used Kentucky babies for our pictures. These are available from me. If you email me, and you'll get my email at the end of the thing, I can send them to you. So all you have to do is let me know. This is another one we did. It talks about how to share the ABCs of safe sleep. I've known of a couple of child cares who have actually laminated these front and back and posted them on the wall in their nursery. It's a good way to share it. We have done these sheets for probably 30 different situations. We have them for nurses. We have them for home visitors. We have them for DCBS workers. We did one for grandparents. We tried to pull out those ones. We have one for a babysitter that's a very simple one-sheeter that isn't overwhelming to that 16-year-old who might be watching the baby. And all of those are available. You can download them from the website. They're all in PDF format, so all you have to do is print them. Or if there's something that you want, and I know that some of the small counties don't even have a color printer or whatnot, all you have to do is contact me and I will make sure you get what you need. Just another reminder to stay close but sleep apart. So along with safe sleep, the next thing that happens is, well, what if my baby won't sleep? So we always throw a kick in there for the never, ever, ever shake your baby. When a baby won't sleep, check to see if they're hungry, tired, need changing. You can change a baby and 20 minutes later, they might need changed again. That's just the way it works. Hold the baby close. You can give them a warm bath. Walk and sing. Maybe the baby just needs a change in atmosphere, taking them out and going for a walk. Anything like that can help. And even though you've done all those things, the baby still may not stop crying. And we really need to push across to parents that no matter how frustrated you get, you should never ever shake a baby. And that doesn't mean that Uncle Tommy, who's bouncing the baby on your knee or doing a little airplane thing, those are not things that will cause the baby to be hurt from being shaken. When we talk about shaking a baby, we're talking about a very violent, forceful, that anybody who saw it would say, oh, that ain't right. You don't do that to a baby. So here are some resources for further information. The National Institute of Child Health and Human Development has a lot of free materials as well. What I recommend from them is they have 3 videos. They have a video for safe sleep, and it's a bunch of families who are talking. We've used it for a long time. They also have it available in Spanish. They have a new video that is aimed at grandparents and other caretakers, and this time they got Smart English and Spanish are on the same DVD. So those can be ordered. I just got my first batch of those, and unfortunately they're, again, if you're just ordering them online, you can only get 5 at a time. But if you call them and tell them, I've got a presentation with a foster grandparent group and I would like 20 of them, they will give them to you. Of course, our website, the American Academy of Pediatrics, all of the primary players in this. So again, this is our website. I'm Luann Cottrell. That's my email address. And any of our materials, if you have any questions, they can, you can get a hold of me and I will be more than happy to go from there. Any questions? Okay, Joy.
Thank you so much, Luann, for sharing the important information about the A, B, C, and D's of safe sleep. We have, as you all know, approximately 50 to 55,000 live births in Kentucky each year, and we want to do everything possible to assure those 55,000 babies stay healthy and in their alone, on their back and in their crib. Yeah, absolutely. All righty. Next, I'll invite Paula Goff to come up front. Paula is a branch manager in the Maternal Child Health Division. We've got 2 presentations back to back this morning from the Maternal Child Health Division. So glad to have you all both with us. Paula is going to be speaking today about the HANDS program and financial management steps to success. It's my understanding that this presentation was also provided to CADA on Tuesday to the local health department directors. If for some reason that your director wasn't able to participate in the CADA meeting, this is the same presentation. There's probably some directors who are joining us today, Paula, as well as HANDS staff from local health departments. I sent the PowerPoint out to everyone, so it'll be available for those who want to use it for future reference. So I'll go ahead and turn it over to Paula, and thank you for being here today in Dr. Shepherd's place. And you'll just want to right-click here on your mouse to advance your slides. Thank you.
Well, let me thank Joy for allowing us to present to you all today. We really appreciate it. And I'm glad that the PowerPoint is working. The folks who saw the CADA presentation saw it with a blank screen, so which was a little unplanned, but we tended to get through it. But I know Dr. Shepherd is also, sends her regrets for not being here today, but and would be if she was able to. But what I want to talk about is, that didn't work. Let's try this. Is to talk about the HANDS program. HANDS is one of the programs in Kentucky that we are all very proud of. It's been around for quite a while, since the year roughly around 2000. It actually started just a little bit before the year 2000. So it is a program that has a long and rich history in the state of Kentucky, and is one of the ones, I think, for public health that we can really tout the banners of success with how positive the reaction was to HANDS and how well it has done. The 4 goals of HANDS have remained the same over all of those years. We're looking for health outcomes for both the child and the mother, as well as having safe environments for children and families to live in, and that families make the decision for themselves, they're informed, and they become self-sufficient. It is a nationally recognized effective program. In case any of you haven't heard, because we certainly tout this a lot, is that we are one of 19 evidence-based programs in the entire nation for home visiting. The maternal outcomes, as you can see, we've made an impact, and these outcomes come from actual research on Kentucky mothers. So, you know, the prenatal care was increased. We've reduced, if you're participating in HANDS, we were able to show that there was a reduction in hypertension and during pregnancy, and that the maternal complications during pregnancy were less. Because again, it's that access to good health care. On child outcomes, we are an effective program to reduce child maltreatment, reduce prematurity, low birth weight, and in some cases, even the death of the infant while in the hospital. So I think, you know, overall, as we all look at improving the health outcomes for the citizens of the Commonwealth, HANDS is the place to start. But for HANDS to continue, we really want to look at how do we financially make HANDS work. We have two target populations that we serve in HANDS. One is prima gravida mothers, families. First-time parents, we often call it the CORE program, so some of you probably out who are listening to this and watching also call it CORE, but you may call it prima gravida. We also have multi-gravida services. Multi-gravida services are the newest, and actually I can announce that our regulations that changed the wording in the HANDS regulations from first-time parents to just parents actually were ratified yesterday. So that's a great movement when we think about the history of our program. It's a wonderful thing that has happened. We use multiple funding sources for HANDS. And in that financial infrastructure, there really is kind of, if you want to separate it, we look at what's aligned with the two programs. The core HANDS program actually is based off of funding from the Master Tobacco Settlement. As you know, early childhood gets a portion of the Master Tobacco dollars. Out of that reserved pot, money comes to the Department for Public Health, specifically for HANDS. We take that money, part of that money from the Master Tobacco Settlement, and we use that as match for Medicaid. So we can also bill Medicaid. And so between Medicaid and the Master Tobacco Settlement, we can serve the families who are in the core program, those first-time parents. What's left in Medicaid after we take out the match is used to provide the service, pay for the services for those families who are not Medicaid eligible. Multi-gravida, our newest portion to the program, started really when the federal grants were available to us, starting in fiscal year 12. We started getting federal maternal, infant, early childhood home visiting grants, and there's a mouthful for you, but we refer to it as MCV, just to make it easy. But those grants, there were actually two grants that we have had in Kentucky. One we refer to as formula, and the other one is a competitive grant. But those funds were designated at the federal level to be used for expansion of home visiting. And Kentucky chose to expand that to families who this was not their first time pregnancy, but overburdened parents who were the multi-gravida. We also used in the federal money, also supplied the maternal perinatal depression program, moving beyond depression for those mothers with depression. We provide an in-home treatment for depression with an evidence-based model, moving beyond depression. So those were fabulous, I think, expansions of HANDS. In the last biennium, not this current one that just ended, but the one that began in 2015, state funds for the first time were actually designated in the state budget for HANDS. So we do now have state general funds available to us to support the multi-gravida program. Now, what we look at from our viewpoint at the state, kind of watching the money, is that we understand there needs to be a balance between the core program and the multi-gravitas services. Core is a much more flexible pot of money, and because of that, we really believe that the core program should be the majority of your services, should be in the core, and multi-gravita be the minority of that. And there's a reason for that. When we look at our whole budget for hands, 70% of our funds that are available for core. Only 30% are available for multi-gravita. And so that makes us think things should kind of be aligned somewhat to that kind of a proportion when you're out looking at your services and your families that you're serving. Now, what we do, for those of you who may be new, some of you, this is probably a refresher, we develop allocations and provide that to the health departments for each health department based upon what we think are the projected services they're going to provide to their area, to their region. What happens is that allocation is kind of just like it's like a little savings account. You can only draw down that money if you deliver a service and bill us. It's on a reimbursement basis. So it's not like we take the allocations and divide up the total allocation by 12 and each month you get a set amount. What happens is you have that number that you know that's kind of your reserved pot of money. And as long as you're billing against that, it will decrease. It's just like our checking accounts, it goes down. And you would be able to see what's going on with that. We take those allocations, it's a fairly complicated formula based upon service history. It has an element in it about what's the population, what's the target population, percentages of births, the number of services. And if you remember in hands, services, not every family gets the same intensity of services because it's based on need. So when we look at the allocation, what we're figuring out is how many families and what would be the number of services for those who need the most intensity, and then the ones who need less intensity, and then those who would need the least amount of intensity. All of that is figured out in that allocation. Then we take our pot of money, we prorate it so that we know for each county how much money do they get, each health department. And that's how we do the allocation process. And what you get and what you budget for, and have just finished budgeting just about a month and a half ago, were based upon those allocations. Now, hands, we are very, very fortunate because we have a very rich history of service data. So we can really look at that service data and pretty good, a lot of people kind of fall into a trend that seems to be about the same year to year to year. We send out that initial allocation, what your health departments were notified of early in May, and then we watch it. In our office, we have people who are watching those numbers and watching your service as it goes along, and again, it's going to ebb and flow. One month you may be billing a lot of services, may not happen to the next month, maybe for some reason there's less service. The next month it goes back up and goes back and forth. But there are opportunities throughout the year where we adjust that allocation and realign it, because on our end, we want to make sure that we use the funds wisely and that we support local health departments doing this work. So there are times where we have districts and health departments that are going like gangbusters. They're on a trajectory early on in the year, and as that goes across the year, to meet or exceed their allocation. We start getting a little nervous when they get close to that allocation, because they may still be going on a pace that means they're going to go over that allocation. At the same time, we have others who are not on that same trajectory. They're a little flatlined. They're not putting out the services and using the funds in the same manner in the same amount of time. So we may take money out of that allocation and give it to another district where they're going like gangbusters and they are in need of that money. Now, that can also get reversed. You could have a health department who got more, then later in the year they got less, etc. It can go up and down. It's really like, to me, it's like a seesaw that we're always doing throughout the year, so that by the time we do closeout, we've got that seesaw going across flat. That is our hope and what we always strive for. There are some budget considerations. The master tobacco funds, this is what we use for Medicaid match. But because we use a portion of that for Medicaid match, and our tobacco allotment usually runs about $7 million. But we take a portion of that, that's our Medicaid, match. That little portion becomes $19 million in Medicaid that's available to us to pay for hand services. Then again, that wasn't used for match, we're using it to pay for those non-Medicaid families. Multi-gravity is a little different. It's, again, for the first few years, it was all federal funds. It's only been within FY16, the fiscal year we just ended, that we actually had state funds available to support multi-gravity services. Now in our federal funds, we have, if you'll look at the PowerPoint, there are 2 cost centers that are in red, and that's because that's the competitive grant money that ends on September 30th. So we have allocated all of that money out to liquidate that as of the 30th. So we are done with that pot of money, and our goal with federal dollars is to spend it down to the dime and figure out how to spend that dime at the last minute. Then we also have our state revenue. The state revenue is a fixed amount of funding. The budget comes to us, it says you have X amount of dollars, that's it. It's approximately $6 million. So those are our 2 pots we can fund multi-gravita. The federal funds for McVie have to be distributed to the highest need sites. So we do have sites in Kentucky that get no federal dollars, but they're serving multi-gravita families because they're using that on state dollars. But we have other counties that were in the high risk based upon a needs assessment, and they get the grant money. They use the grant money until it runs out, and then they can switch over to the state funds. So it is kind of always moving the chess pieces all across the board as we look at how we make these funds work and maximize those. We really do need people to be looking at their service array and the families they're serving and the programs and really work towards getting to a 70% of the families served being in the core program. You've got to remember, our multi-gravita funds are capped. There's only so much federal, there's only so much state. And we can't take money from one pot and put it into another pot and back and forth between the core program and the multi-gravita program. So we have to think about that. Multi-gravita does not bill Medicaid. So that's an important factor there by itself, is the fact that there is no Medicaid coverage for the multi-gravita. So, that is something that's on our radar scope and we're working towards, but that has not been approved at this point. You need to monitor your families, your core families, your multi-gravita families, and also remember what your rates of reimbursement are. Because depending upon the type of service, depends upon the amount of money that we're going to reimburse you for that service. So you can project, as an agency, you can project what you think your income will be based upon knowing what services and what types of services and how many. Here's what has had kind of a history to look at what we're comparison of what we project from the state level to be served in hands, and then what was the actual number. And as you can see, the red line is the actual served. And for many years, some years we did a pretty good job of that projection. It was close. Some that we were kind of like, ooh, what were we thinking? 13,000 children and, et cetera. But this last year, we actually served more than we projected would be served. By about a little over 1,000 children, or 1,000 families, I guess I should say. So that raises a little flag on our side to make sure we're watching that. But when we look at,
Excuse me, someone has their mic open.
No.
Could you please mute your mic? Thank you. This graph will show you the families, in terms of families for the two programs, and the number of families. And as you can see, the core, I mean, you look at this and you think, okay, things look okay. FY16, all the previous years, Multi-Gravity has always had fewer families. Well, it makes sense. It's the newest portion of the program. It took years to ramp up, but they really ramped up. I'm telling you, you health departments have been working hard because you really created quite a bit of growth from 2012 to 2016 in the Multi-Gravity program. But look what happened to core during that same time period. It started decreasing. And part of me says, well, you can only focus on so much at a time. So we're telling you, hey, you can serve Multi-Gravity, here's this money, get out there and serve those families. And that may have unintentionally meant, well, we have to focus our resources only on this, and we lost this over here. It's hard sometimes, believe me, I know, to focus on multiple things simultaneously. What's concerning to us, though, is this slide. We had money available to serve the core families, and it's dropping because of the number that we're serving. And if you look over the years, FY15 we were probably pretty good. We were about 77%. We could probably absorb that, give or take. But look where we ended up for FY16, down to the core program only representing 58% of the services. Now, remember that teeter-totter that we're on, that we're trying to balance, and it's not exactly a 50-50 balance for this program. We're looking at 37 Ps. But if they're both at 50-50, neither program is going to be in good shape. And we have to look at long-term sustainability. So we really need people to pay attention to what happens in the core program. And as you can see in this graph, it helps you to see clearly. The red line is what's been served. The blue line was the amount of money that was available. And you're probably thinking what most people look at from FY13 on, it's kind of like, ugh, money was left on the table. We don't really like it when money's left on the table. We want people to take that money and run with it. But you do have supports. That money is available to serve these families. And this just gives you a spent from 2007 to FY16, how much money has been left. And some years we've done better and some years not. Now the core program, remember, these are the tobacco dollars. And we have been very, very fortunate in that decisions that are made at hot levels way higher than me, way higher than Dr. Shepard, and actually higher than the Department for Public Health. They allow us to roll that money forward. It's a carry forward money that we can then invest in the next year. They've been very generous to do that. But at some point, our fear is they're going to come and say, hey, y'all, look, you've got a year you didn't use $8 million, and then the next year it was $6 million. You all don't need that much money. And that's concerning. So we're wanting you to get out there and build up your core program. Now, multi-gravity is a whole nother beast. And if you see on multi-gravity, this chart looks almost the opposite of the one for core. You've got that great exponential growth in the number of families served. Absolutely great. And you're just about at the cap of the monies available for multi-gravity. We really will have a very difficult time if that program continues the growth that it's on. That will be very difficult for us. The other things that have happened that I think that people need to really think about, HANDS is a program that was designed, its sustainability was originally thought to be a model of 3 to 1. 3 professionals to 1 professional. Paraprofessionals to 1 professional. And there are a number of positions that are required in HANDS. It is a labor-intensive program. There is no two ways about that. Supervision is required. As an evidence-based model, We are concerned with the fidelity to the model. We know that HANDS is effective when it's implemented as the model dictates. So supervision is one of those requirements that we're finding through our QA process that might be one that once in a while gets kind of overlooked because people are busy, they're doing other jobs in the health departments, etc. But we really, that's part of your cost. And we understand supervision is an expensive cost, but it's an incredibly critical cost to make sure we have quality services for families and children. Some other things came out through our QA reviews that we've been doing. First of all, you need to make sure at your health department that you're providing enough services to sustain the program, but you must also bill them. We have found sites where they had the documentation, everything was in line, that they could have billed for services, and it just never made it over to the data clerk to get entered in and billed. That was missed opportunity. That was some of that money left on the table. You know, your family support workers are going to need to do 3 to 4 home visits daily. And at least 60 for you to really be generating enough revenue to cover their costs. Now some of you that might, for some health departments that might be higher, if you are a health department that has primarily professionals working HANDS, your costs are going to be higher. So that means you need more revenue to cover those. You have got to look at your numbers and do an analysis about do you have a decrease in the total number of families you're serving? Why is that happening? Is it only in core? What about your multi-gravida? What is it that you can do to increase your numbers? Again, it's that outreach. Your CDP report 116 will give your health department, and your financial people in the health department certainly use this report frequently, but it gives you the total expenses for your health department. So they can extract who's working on HANDS, what is the cost for Polygolf to be this work in HANDS, and they get the total cost for that. They know you can figure out what is it I gotta have to cover the salary and fringe. What do I have to cover my travel of my staff? And that's, again, that comparison of revenue. In HANDS 2.0, which is the database system that's used, you can always determine how many services have been completed as of this date. Of those services, what was billed, so I know what's pending. You can also find out what were you paid. That's out of the HANDS system. Now you also have CDP on the other end. But there is data available to you, and so one of the things we are doing to help you with this is making changes to HANDS 2.0 so that when you pull up the home page of that system, there will be a dashboard there that will give you critical information about your site. What was your allocation? How much have you billed against that allocation? How many families do you have in core? How many active families do you have in multi-gravida? Kind of all of that kind of key number, just quick glance on a daily basis of what's going on for your system. And we'll compare it. Our goal is to also have a state profile there too, so you can look at how are we doing, how's the state doing. You got to figure out if you're a profit or loss, where are you on a profit loss? And if you need more revenue, how much more do you need? And that has to finally be figured out into how many services is that, based upon what those reimbursement rates are. If you need $50,000, well, you need to figure out, okay, here's the money, here's the reimbursement. What do we need to do to get that recovered? And how many staff does that take? Because again, staff is your big expense. So to improve, again, you need to make sure you have enough active families. Now, we do know that there are caseloads out there with people that have inactive children on the caseload. They just haven't gotten around to exiting them out. But what happens is, I'm the administrator, I come and I look and I say, oh, we've got 10 new referrals. I've got to put these 10 families with my staff. How am I going to divide who gets which referral? I look at the caseloads of my staff and I say, oh, You know, she's full. This one, she can take 2 of them. Oh, here's over here, she can take 2, whatever it is. But it might be that Jo, yes, she looks full when you look at the numbers, but maybe 3 of her cases are inactive. She's not doing anything with those families. So is carrying inactive children on the caseloads preventing you from deploying your staff efficiently? You've got to look at that and be aware of that. You've got to realize that up to 25% of your visits will be missed. That's the data, the research shows that across the board. So plan for that. Plan for that in your revenue. Think about, okay, if I know 25% is going to be missed, now what you want to do is try to reschedule as many as you can. But there will be some of those that will be actually lost opportunities because the family says, oh, we don't need to make that up, you just come here next time. Well, you lost that opportunity, but you had to have staff ready to go. So you've got to watch for that, and you have to plan for that. Know what your average number of services are per month. What's going on? Make sure you exit those families who have already exited or families who have said, I no longer want the service. Be sure your records are up to date. You know, things that you can do to look at why your numbers might be down or not enough active families. Look at your exit reasons. We gather from families when they leave the program voluntarily, we ask them, you know, why? And there are exit reasons. Find out, is there something there you can have impact on? What about the families who refuse? You've brought them in, you've done the screening, you're thinking this is a viable referral that's going to look like a viable, eligible family to work with, and they say, thanks, but no thanks. Why? Is that something you could, again, that you have influence over and can impact and change? Look at your referrals. Where are you getting them? Are your key referral sources actually keeping up with sending you referrals? Have your referral sources changed? We hear anecdotally, a lot of people say, well, we don't get as much foot traffic in the health departments. That's really hurt our referrals. That's true, that probably did. Are you walking outside of the health department to find where those families are? If they're not coming to you, you've got to do something to go to them. Again, those missed visits. Can you reschedule any of them? Can you make them up? That's important to see if you can do that. With outreach, just doing what you've always done in the past may not get you a new result. So be aware of that. We want you to get you into alignment. So we actually are saying the policies that we're going to be working with the health departments with this year is that you get your program in balance. If you are a site that is getting near to your allocation in multi-gravida, you need to contact our office. You can't just close enrollment, but you may need to close enrollment. And what we want to assure is those families you're already serving that have committed to the service, are excited about the service, that those continue. So we will work with you to figure out when's the time that you say no more new families for multi-gravida. Families may enroll in HANDS at least twice if they need to. The first time is a first-time parent. They have a second child. If they are still eligible, they can enroll with that second child. However, we are finding some of the families in multi-gravida are now on their third and in some cases fourth child. Again, the HANDS model says that we are effective in helping families become self-sufficient. We increase their knowledge of child development and their skills as parents. Well, if we're up to the third and fourth time using the same curriculum, the same methodology, you got to ask, what's not working? That is not the model of HANDS. So, again, no third-time participation. So we'll be working with sites on that. And those of you who are really familiar with the HANDS program, you know that it works on a level system. It's kind of a triage of the types of services people need and the intensity level. Level 0 is that least amount of service, and the intention had always been it would be for a very limited amount of time. So the family either is going to commit to doing HANDS or they're not. Well, we do have sites that have families in level 0 for up to a year. So that means that the health department is expending resources, expensive resources, for that one time a month amount of $110. Now, in all likelihood, it cost them more than $110 to do that once a month service. So the question, we're really looking at it, that's not a good use, that was not the intention. We are going to be sending out clarification to all the health departments about how to use level 0 more effectively and appropriately. Most of the sites, almost all of you across the state, have reserves in Cost Center 853. Now these are your monies in a reserved cost center. You don't have to bill against this to use these monies, but they do have to be used for hands. You can use that to help revitalize your outreach to first-time parents. You can use those funds to cover costs for no-shows. If you have cost overages above your allocation, then these are the funds to use to cover your costs. We will do everything, and we have done everything we can do year after year to make sure that we can cover allocations, but we cannot guarantee that. So make sure that, again, if you are one of the programs that are in that position, that you use your reserves to help with those costs. We've just been notified that we're going to get an additional $4 million in Master Tobacco Carry Forward. That will be going to the core program that you will be able to bill against for services. You will have to bill that, but there will be allocations going out to sites to build those core services. So you have some extra money to help you out with this. Many of you who attended the Hands Academy got a little document called Handy Notes. It's a little booklet of resource tips that came from your peers. Not from us in Frankfurt, but from your peers. And there's a whole section in there about outreach and engaging families and retaining families. Use those. If you need more copies, let us know. We can send you, the tips. It's a really nice little resource because you might find a little gem in there that'll work great for you, and we want you to do that. You have assigned technical assistants who can help you network with other health departments who, that are either struggling or are very successful in those same issues you're working on. And so again, that peer-to-peer support, we can help with, the technical assistants can help you make sure that you get in touch with those people and can network with them. And again, you can always contact us here in the central office. We are more than happy to help. If you call me or you email me, I might not know the answer, but there's a lot of really smart people right down the hall from me, and I go and rattle their cages often. So I have no problem, and they seem to be pretty nice. They always give me the answer, so I'll just keep using that method. But again, we want to help you be successful. We know you do tremendous work in Hands, and it's because of your work that Hands is as successful as it is. We currently have our federal reviewers here this week, and I say your work has helped us shine as a state in their eyes, and that's really important because it'll keep Hands going. Thank you, Joy. Hope you all have a good day.
Thank you, Paula. I wanted to ask the field if there were any questions for Paula before she slipped out. Some very valuable information, Paula. Thank you. You did an excellent job. And for those of you all who know that your director either attended CADA on Tuesday or they've received this information, that's great. If you're not for sure, please send this information to your local health department director so they can be aware of that, as well as your financial folks and your Hands program staff.
Yeah.
I don't have those names pulled out specifically, but certainly in many cases the local health department nurse leader may supervise Hands, or certainly they're right there nearby, and so they can share that PowerPoint presentation with you.
And we'll be sending it out to the Hands coordinators too.
Okay, so Paula just mentioned, in case you didn't hear her, that The PowerPoint presentation will also be sent out to the HANDS coordinators for their information as well. Yeah, okay. Thanks, Paula. So Kim, what I think I'll ask you to do, if you don't mind, would you mind to email Shannon Bishop for me? She's our next speaker.
Oh.
And she's MIA. So if you can track her down, I've got many announcements. I'll go ahead and do a brief commercial break and share those announcements, and then we'll have Kim see if she can track Shannon down.
Excuse me?
I wanted to let everyone know that, come on in, ladies. First of all, I wanted to make sure that everyone was aware that the Department for Public Health has a new commissioner. Dr. Hiram C. Polk joined us about a month ago. And Dr. Polk is a surgeon by training and background at the University of Louisville. Actually, the surgical center there is named after Dr. Polk. He's trained over 300 surgical residents in his past career. He hit the ground running, certainly, and has a keen interest in public health and many issues that impact public health. And so we're very fortunate to have him here. He is not only well known around the Louisville region and medical schools across the state, but he's also nationally known and internationally recognized and a renowned surgeon. So again, we're fortunate to have him here. If you have an opportunity to be in meetings with him or have opportunities to meet Dr. Polk, please introduce yourself. And as a surgeon, he's very familiar with working with nurses, and I had the opportunity to have a great conversation with him about local health department nurses and the fabulous job that you all do out there each and every day. The second announcement I'd like to share is that the fiscal year 17 NEC meeting, we'll have our first meeting of the year next Tuesday, the 23rd. The focus for this year, a part of our focus, I should say, will certainly be working with ECW and collaborating with our ECW and OATS partners on the system build function, as well as the rollout and testing, and providing input and insight to our partners to assure a successful rollout of ECW. We have 3 new participants, members of our NEC this year. Anita Owens, who is the nurse leader at Green River District, she will be joining us. Julie Miracle, who's a nurse with the immunization program, and then Melody Stafford, who's a nurse with the Women's Health Division, will also be joining us. We had a couple of individuals who retired at the end of fiscal year 16, and so we wanted to bring on some new participants to make sure that our group was fully staffed. So that meeting will be next Tuesday, and I'll be sure to keep you updated on their activities. Next, I wanted to mention about the flu pricing. I've received a couple of emails already about the flu influenza vaccines, and I know that many of you, the local health departments, are anticipating receiving your flu vaccines within the next week. I wanted to let you know a couple of things about the status of that information. One, the MMWR has not been released yet for influenza, so we don't have, as a department, the official influenza recommendations for this flu season. So we're waiting on that so we can assure that the flu protocols are up to date and consistent in alignment with the CDC. Secondly, local health operations is working on their annual billing and coding memo for you all, and so that will, that's in progress, and they hope to have that out hopefully next week, or certainly we'll be able to send that out in conjunction with the MMWR guidelines and any changes in protocols. And then thirdly, the VIS statements, as you all are probably aware, that those don't change from year to year anymore, unless of course there's a change in the indications or the recommendations for the flu vaccine. So if all remains the same, then the VIS statements will also remain the same. But just to let you know that we'll be aware of those, any changes that may be made, and if there's new information, we'll be sure to send out those new VIS statements for you to use in your clinics. We wanted to also announce that the Madison County Regional Training Academy has a new director. Her name is Rhonda McGuire. We're very glad to have Rhonda with us. I know she's already as well hit the ground running. She replaces Libby Hess in Madison County at the Berea Clinic. And so you'll be receiving emails from Rhonda McGuire now instead of Libby Hess for upcoming training information for the comprehensive reproductive exam training or the STI training, and with the next training being available September 1st. Wanted to make sure that you all were aware of that. If you have any questions or about those trainings, or if you have a nurse that you would like to send to the comprehensive reproductive exam training on September 1st, please let me know, or Rhonda McGuire know. She's in the global lookup. Wanted to also let you all know that that the University of Louisville Well Child Preventive contract is in the approval process, and as many of you all know, this is the contract that supports and funds the services for the trainings for our local health department nurses to attend, so they can become credentialed in well child EPSCT exams and provide those services and bill Medicaid in local health departments and the school health settings. So that contract is in progress. We hope to have it approved in the very near future, hopefully within the next week or two. And so I wanted to make everyone aware of that delay, and I apologize for that delay. And so you can make sure that your school partners, other partners that you may have from a contract perspective, let them know that there's a delay in that contract. And I think it's just from simply the volume, not that there's any concerns or problems with it. I think it's just getting the contract through the approval process. If you do have nurses that you need to have go to the training, if they need to go ahead and start their prerequisites, those modules that are on train, you can contact Susan Lawson or Luann Cottrell, who was here this morning for the Safe Sleep campaign presentation, and they'll be able to help you through that process and have your nurse's name added to their list so they can go ahead and be expecting them. Once that contract is approved, we can go ahead and get those nurses through the training. I wanted to let everyone know, remind you all about the APRN conference, which will be held this year on September 27th and 28th at my old Kentucky home in Bardstown, Kentucky. Again, the conference will be provided free of charge to our local health department APRNs. There will be a small fee for retired APRNs who do choose to come back. We've had several of those come year after year. Dr. Glenn Farr will be providing the pharmacology nursing CE, which is required for the APRNs. He'll be here on Tuesday, September 27th. So in the event that your APRN may only be able to attend one day of the conference, they'll probably want to come on that first day so they can get their pharmacology CEs. I'm still working on the second day agenda, But I promise that we'll have a great conference and a lot of relevant topics for APR in practice and public health practice. So I hope that you'll be able to send your APR in to Bardstown in September. And then lastly, my last announcement, and we've got our folks from the lab here, so I'll turn it over to them. Lastly, the NEC has provided some great input about topics to cover for a new local health department nurse leader orientation. We do anticipate that it'll take approximately 2 days to cover that information. And I'm looking at dates in October after the APRN conference. And as soon as possible, I'll go ahead and send those dates out so you all can have that commitment on your calendar. I know just for this year, there were probably 5 to 6 new nurse leaders who transitioned on July 1st or August 1st to a new role as a nurse leader. And then there were probably that many again, another 5 or 6 nurses who have been in their role 6 months, 12 months, 18 months, who certainly are invited to come as well. So I'll be sending out the agenda and topics, and if you all have any input on subjects that you all would like to discuss, certainly I'm open and receptive to having those on the agenda and talking about those as well. Okay? Any questions about any of the announcements I made during the commercial break? Any questions? Okay. If you do, you're always welcome to email me or call me. I'll be glad to help out. Okay. So next what we'll do, we're able to track down Shannon. Okay. So we'll go ahead and I'll ask Robin and Leanne.
But Michael is here if you wanted him to come in
Okay.
and say anything.
Okay.
I'll have to just call Ron and tell him.
Yeah, would you want to do that? That would be perfect. Thank you, Kim.
You're fine.
So what I'll do is go ahead and ask Robin and Leanne to come up. Are y'all gonna do a tag team or?
I have one thing to say.
Okay, okay, I'll go ahead and put a present.
In check.
Yeah, okay, okay.
Did you get my presentation?
I
I sent it kind of late.
Yeah, that's okay. I've got it here for you and I'll go ahead and pull it up. I received Robin's presentation here this morning, and so I didn't have the chance to send it out, and so I'll send it out certainly when I get back to my office, okay?
Okay, yeah, I was waiting on a couple of answers that I didn't receive yet, so
Okay.
I was hoping to add it to the presentation.
Okay,
But I guess we're still,
we'll get you set up here.
it's gonna be short and sweet.
Okay, so do you want Leanne to speak first before your presentation, or how would y'all like to do it?
She
Okay.
would like to have the floor.
Okay, so I'll turn it over now. Thank you all. I'll turn it over first of all to Leanne Bates. Both Robin and Leanne are from the Division of Laboratory Services, and they've really been open and receptive to taking on this role of updates on a regular basis with the ITV. So I certainly appreciate your all's willingness to come over and share the latest and greatest with laboratory services. Leanne?
Well, hello, everyone. I just want to take a moment to say thank you all for actually signing up for the FedEx website for packaging and shipping.
Okay.
If you do not have an account on the FedEx website,
Okay.
please be sure to email me and I can get you set up for that. The only one note that I want to take just a second to say is if you're going to send multiple boxes on one day, we do not want you to do that. Please make sure you put multiple samples in one box. And if you have to send more than one box, please do an overpack. And if you're not familiar with an overpack for packaging and shipping, please contact me and I can walk you through that because we are working off of grant money. And so we want to keep our costs down, and when you send 2 boxes, it's like $16. If you will make it condensed into one box, it might only be $8. So we're just trying to preserve our money. So if you all have any questions about that, please contact me.
Sounds good. All right. Hopefully mine will be short and sweet. Hello, I'm Robin Cotton. I thought that today's presentation we would do frequently asked questions. And it seemed like we've had a lot about the CLIA application. And I believe one of the reasons is that a lot of the certificates at the local health department are nearing expiration, and there has been considerable turnover, and we have actually had a couple of lab directors leave, which has kind of put things in a quandary for a few, and especially one was unexpected. Now, I am not an expert on CLIA, so I'm learning along with you, and certainly will field any of your questions and try to work with you on getting the answers. I do have Mr. Sid Spears' information, contact information. He's with the Office of Inspector General right here for the state of Kentucky. That's who we have as a CLIA inspector, and he has allowed me to give out his contact information. And no question is a silly question, that anything that we can't resolve or he can't, he will certainly try to find an answer for you through the Washington office or wherever they're located at. Okay, so I just want to go briefly. I think most of you are familiar that when it comes to the CLIA application, that you can get the form online, and I've provided the website, and I'm not going to bore you with that because you can get the presentation after this meeting in ITV. But as I said, a lot of your certificates are nearing the 2-year expiration. And so what should happen is that you should receive an invoice in the mail. So that's something before, look on your certificate. If it's getting ready to expire within, so many months and you haven't heard anything from whoever does your billing, kind of check back with them. And the reason I'm saying that is because I had a phone call yesterday from someone who said my certificate is expired. And so that really, surprised me a whole lot, and I was very, surprised about that, and so we wanted to, attack that right off the bat. And so the first thing I asked is, did you pay the bill? And so she wasn't sure, so we did some checking in, and she had actually paid the bill. However, I guess maybe what had happened is that she did not receive the certificate, or we're not sure whether it was sent or who has it. So that was a good thing that we did check up on it. So I just want to make you aware to look at your certificates, note when they are expiring, and check to see who's getting that invoice and it is paid. And if there is a situation or a problem with that, as I have on the bottom of this slide, that you can always call the Office of Inspector General here in Frankfurt, or Mr. Sid Spear, and I have more contact information for you on that. Now, a lot of people out there are confused because of the turnover, and all of a sudden they have to deal with this. So I've had a lot of questions like, when do we fill out that application, or do we have to? The only time you really have to fill out after you initially fill it out, which everyone has, because every health department or district is on a certificate. And the only time you really have to complete another application is if you have what's called a major change. For some reason, you're going to go from certificate of waiver to PPM, or downsize from that to the other, which we've had that happen. Or you have major changes in personnel, address, facilities, something like that. If you're not sure, you can always call Mr. Sid Spear, or they've got great instructions with the application of when you think you need to make that change. The biggest change that we've had is director. Whoever is on your certificate is responsible. So like I said, we've already had 2 situations this year where the director left unexpectedly, and the other director left, and no one seemed to know that they needed to make this change. So whoever is on that certificate is actually liable for the laboratory. So when you make that director change, and I'm going to speak a little bit more about that, so just hang on. When you complete that application, you can do a lot of different things. You can mail it, you can email it, fax it to Mr. Sid Spear, and I have all that information. When you get your new certificate, it would be nice if I have a copy for the file, so I know that I have that on file in case there's ever a question, or there's personal turnover, or we know that that's been taken care of. And then you can see my comment here about Mr. Spear. He would like to note that for his official records. We had a question come in about someone was on a certificate of waiver. And they wanted to add another test, a Hep C, which, another waive test. So as it stated here, that if you're on a certificate of waiver, you can add as many as you want. You don't need to make an application for that. You don't need to notify anyone. But you just need to make sure it's waived and you follow the manufacturer's instructions. I think most of you all know that you have to follow those manufacturer's instructions, because once you tweak them or do something different, then you're considered high complexity, and that's really not legal, and that causes a lot of ramifications. But if you have questions about that, you can contact me. But I wanted to go over this just for a few minutes, so bear with me, because we've had a situation on a lab director who had left, who was involved with PPM, and this is serious, because this was the only person at this facility who provided this service. And this is public health. If I was at this health department and I wanted to have a KOH and wet prep, and now I can no longer provide that service because my person just walked out the door, you want to try to get as fast as you can that continuity of services, because where else are you going to get it? So this is a very serious service that you provide. So we had a situation to where there was an individual that was serving as a lab director for another facility, and they were going to share them. So when we started going through the application, we were looking at the qualifications. So whoever is going to step into that position, and I know a lot of times it falls on the laboratory, because laboratory personnel are not as versed with this. So what do? One of the things, and I don't want to keep punting it back and forth, but whoever's going to step in that laboratory director position really needs to know what the qualifications are and if they're qualified. So that's their responsibility, because if they're going to run a laboratory, they need to make sure they're qualified and they have those qualifications. So there is a regulation, and I have it listed here on the slide, the 49.3.1357. And why this is important is because it specifies, which most of the laboratories, I believe, I don't know this, for sure, but I think a lot of them are run by what's called a mid-level practitioner. So when we got to looking at this, and I am by no means a nurse or know anything about nursing, Joy can back me up on this, but I didn't know the difference between an APRN and an NP, and this is vital, because if your lab director was the only one at a facility performing the KOH and wet prep, the PPM, okay, and they're considered a middle, and they're an APRN, they have to have this NP. They have to be a nurse practitioner. We've checked this out with all the way up through the federal government and the highest of the CMS. So this is a regulation. So just because they're an APRN is one thing, but they have to have that NP to be doing KOH and wet preps. I don't know, this is what we found out, because we researched this. Did you have a comment, Joy?
Well, I was just gonna say, in common practice, the terms APRN and nurse practitioner are interchangeable.
Right.
So did the federal government make that distinction as far as two different types of practitioners?
All I know is that this is what the regulation states, and because this federal regulation right here is what they pointed us to. They actually defined it in the regulation. So when they had the regulation, they said the definition is nurse practitioner.
Right. And so what you've got up there is correct.
Yes.
Robin, as far as the degree,
Yes.
Per the Kentucky Board of Nursing, and what the level of licensure is, requirements for an APRN in Kentucky. So they have to have a master's degree now, or in their certification, whether it's a CNM, a nurse anesthetist, or a clinical nurse specialist. I think the question that I would have for you, and maybe some of the local health departments would as well, there are some APRNs who are certified in women's health, and they obtained their certification from Emory University. And so they were grandfathered in when the state laws were changed. And so if we need to research that and have that conversation offline, we can, unless you're saying to me that those individuals would not meet the qualifications.
As far as my understanding, and I can check with Sid with OIG, hopefully we are moving from this point forward
Okay.
on this.
Okay,
That's all I know at this point.
Okay.
I don't wanna shake any, trees or
sure,
let sleeping dogs lie, because especially if they have that documentation.
Okay.
That's not been an issue that I am aware of or I know.
okay,
But if it becomes, then we're gonna further, research that.
okay, because the nurses who have received that certification, they would not have necessarily, based on the information you have on your previous slide, they may not necessarily have their master's degree.
Okay.
And so we just need
And
to
they are the
find,
lab director, and they're doing
I don't
PPM.
know that.
Okay.
We would, that's what we would need to research with our local health departments.
Yes.
But certainly it sounds like we'll need to have a conversation and send out some, some clarification on that, okay, after you talk to Sid.
Yes, yes.
Okay.
That would be fine.
Okay.
We might have a three-way on that also,
okay.
because like I said, you're more the expert on the nursing end. I learned a lot just from this myself.
Okay, okay,
And so what I'm giving you is just verbatim, any of the APRNs that are becoming a lab director that want to perform, this is PPM now.
okay. Oh, it's
So
PP, only for
This is with
PPM.
including the PPM, yes.
Oh, okay,
This is where it makes the difference, yes.
okay.
Yeah.
So, but the same regulations apply for both WAVE and PPM as far as a master's degree?
All I know is it's just for the PPM.
Okay,
But I can tease that out if anyone is concerned about this, but this is for the PPM.
okay, that's a
They
good,
have to have a higher level because the PPM is considered a subset of the
sure.
high complexity.
Sure. Do you know off the top of your head, Robin, how many of our labs have PPM certification? Because the majority are CLIA waived.
Yes.
Yeah, so it may.
As far as my understanding, I think is Lake Cumberland, I don't know if they're on,
Yeah.
because they went, I believe, down.
Yes.
I think everyone right now, I know for sure, let's put it this way, that no one is high complexity or moderate complexity,
Right.
no one.
That's right.
So they all have a certificate of waiver, and then some of them have only this subset of PPM.
Okay.
And that's it.
Okay, so we can identify those local
Yeah.
health departments who have PPMs, and then we can take it one step further and see who their lab director is, and we
Yeah,
can.
and whether they're actually performing the PPM.
Yes.
See, that's where another, the whole issues was also.
Okay,
And then this is just on the website, so the lab director can look at this further, because whoever is going to be the lab director, they just need to make sure they have this documentation. And they can call Sid and the OIG if they have any questions, any reservations at all, or are not sure, to help them walk through that process, because I'm not the expert when it comes with this, what all the state licensure they need or show, the education and all that. But I will say this, if the lab director, okay, now this is going to do PPM, and that's the person you have designated, because no one else maybe in that health department can do it. That lab director, which is in one of the cases, and I can't remember which health department, they're gonna go on and get that certification. They're gonna get that extra training to do PPM. And they can do that by going to this, and I've already instructed them on the website, they can take this course. And then after they take the course, they have to do a PT. Okay, so what happens if I want to go with Wisconsin, and there's a whole list of where they can get a proficiency test. But let's say there's none available for a couple of months. And I don't really want to take a whole lot of time, because this is probably a very unique situation. But the lab director can do what's called a peer-to-peer comparison PT, where they can call up another health department who's versed in it. They can do a test from that lab to, that lab. They can, put together a little test for them, and they can take it, document it, and they're good to go. They consider that as a peer-to-peer, and that's straight from SID also. Okay, so I apologize if this isn't exactly what everyone wanted, but trust me when I tell you, there's been a lot of questions about the CLIA certificate, because there's a lot of people concerned, and they haven't had to deal with this because of the turnover and because of the unique situation. So it's really good that we're going through this, because you never know when you're going to be in this kind of situation or when this is going to happen.
And maybe we can invite Sid to come. I can invite Sid to come as well, you know, to present it, maybe the next ITV.
You can, yeah, that would be a possibility. I was going to say he's overwhelmed, but you can
Okay.
try.
Okay.
Okay, the next question I've had is what happens when I have a procedure, which happens to us at the state lab, and I just use this glucose procedure for an example, that you have all the review and revisions already, all the lines are already accounted for. So now what do? I'm on my very last line here, and what do I do next? Well, I'm just going to pose a couple of examples for what to do, because some of these procedures don't change. The manufacturer don't change instructions or directions, so we've had them for years and years and years and years. One of the things you can do, since you have these electronically, is you can take this part right here and create your own sheet, like a continuation page. I mean, you can put up at the top what the procedure is, what your health department is, who's the lab director. Now, why would I want this up here? One of the reasons I put this extra line on this one is, let's just say if you had a change in a laboratory director, and you already have your first sheet already full. So how are they going to sign a new sheet? So that's why I added that in. But you can design these however you want. And all I did was just copy and paste. I took that renewed and revised, and then I would put that right with my procedure. So if an inspector or somebody wanted to come in, an administrator, and look at that, they see this sheet is full. Right behind it is a continuation page where the director has actually looked and signed off. So you can design it however you want. Just make sure it has a procedure name, your health department clearly on it, and then, you know, I was just thinking ahead that if you had a different director, because this more or less is for continuation, director, initial and date, as you're going through revising and renewing. So that's just an example. You don't have to use that. That's an example for you. Also, a lot of people are not sure, you know, what kind of a sheet to put in for their employees. Like I said, this is just an example where you can put, you know, up here what page it is. Here is the procedure. Here's my health department, each employee, whatever you have them do. Annually must sign with every revision and update. So there they print their name, they sign it. This is my annual date. So it's very easy for someone to come and see, oh, when was the last time you read this? Well, you need to reread it again as a refresher or retrainer. This is only example. You don't have to use it, but this is something we do. We require in our state lab, I don't care if you've been there 20 years and you can quote the whole procedure. Every individual, every lab person that performs tests must read every standard operating procedure yearly and sign off. This is just an example if you want to use it. So that was a big question what to do, because most of your procedures haven't changed and they're all getting filled up on the first page. Okay, and then I'm giving you the context. Also, just a couple of quick things. I had sent Joy, because I had gotten a notice from the Wisconsin State Laboratory of Hygiene, those of you who do the HIV proficiency test. For the last couple of years, the lab has provided that fee. We have a new director, and I haven't consulted with him if we're going to cover that fee. I've also talked to the HIV program. In case we don't, will they? And we'll work something out. But I have a list. I believe it's 16 sites. 5 of them are the district. And I gave it to Joy to send out to the health departments to see if you're still participating. Because if we're going to pay for it again this year, HIV testing, I want to make sure that you're going to receive it and that you still want to do that. So I sent that on to Joy, and
I'll get that out today, Robin.
right. And then there was one last thing that someone asked me about fecal occult bloods and the cancer prevention program. And I have kind of reflexed that back to here at the state. I know that they're looking at some American Cancer Association regulations, because I think the recommendation is they're wanting to move away from the guaiac paper. I don't know this for sure, because they're looking at the testing possibly being more specific or sensitive or a better indicator. I'm not quite sure about that. Also, I can't tell you much about the funding. I know that there was funding for certain kits and provisions and reimbursement. I don't have anything to do with that. I believe that funding had run out with the fiscal year. I'm not sure from that point on. I have just asked different local health departments, if you're concerned about that, to contact the people here at the state for the
Yeah.
cancer, colon.
Colon cancer.
Colon, yeah.
And Janet Luttrell has sent out that information, but I'll
Okay.
make a note to ask Janet, if you're getting those questions, I'll make sure to ask Janet to resend that out to local health departments so everybody can have the most current information on
That
that.
is correct, and I did do, as you know from the last ITV, the OC Light had a
Yes.
change in it. I do have that new revision in that new SOP if you need it, but I think that was on hold with some of the health departments. I wasn't sure if they were continuing with the fit testing or not, depending on the funding. So I'm here to help however I can. If you need it, just email me and I'll be glad to send that procedure out. And that's all that I have.
Okay.
I don't
So
know if
we've
there's
got
anything
some,
else.
thank you, Robin. We've got some deliverables that we owe to the field as far as clarifying for our certified
Yes.
APRNs for PPM lab directors.
Yes.
Right, okay.
Oh, yeah, and I just have one other thing.
Okay.
If you go to the www.cdc.gov, I don't know if I put this in the last, but they have a provider perform microscopy procedures. If you just put that in the search box, these booklets are free. Get them. They have ready test. They have a lot of free materials. Please use that website. A lot of educational things. That's it. Okay. I promise that's it.
Thanks, Robin. And again, I'll send out your PowerPoint to the field when I get back to my desk. And also I'll contact those, forward on that email that you sent me this morning about.
Yeah, the sites that if they're gonna continue with the HIV testing.
Okay, okay.
Yeah, we won't worry about the funding just yet.
Okay, all right. Thank you again, Robin. Yes, any questions?
Can we ask 2 questions before they leave?
Absolutely.
We're
They're
right
right
here.
They're right, she's right here. Go ahead.
Okay, we're one of the sites that's always participated in the HIV proficiency because they told us we had to. So is it optional? If we're gonna do OraQuicks, is the proficiency testing optional?
I will have to get back to you that because all I know is with the certificate of waiver, you have to have some kind of proficiency, something in place for every lab test that you have. You have to perform some kind of proficiency test. And a lot of people go with the Wisconsin because it's available and it's a good test, and they use that, especially within their district, to pass it around and take turns with that. There's some kind of, you have to have some kind of quality assurance program in place. Some way to prove that your employees are proficient. Now, as whether that was mandatory or not to do that one, I cannot speak to that, but I can.
Have you talked to Greg? Have you talked to Greg Lee?
I haven't talked to Greg.
Okay,
over that.
okay. Jennifer, let us do some research on that and make sure that we've talked to Greg Lee and make sure our lab and the program folks are
And that may be their recommendation.
Yes.
Which is a great recommendation. What health
She's
department?
Jennifer Hunter, she's the nurse leader at Northern Kentucky.
Northern Kentucky,
Uh-huh.
okay.
Yeah.
Actually, this is Lisa. Hi.
Oh, hi Lisa. Y'all are starting to sound alike. Yeah.
We're like an old married couple.
Okay, yeah. Okay,
Yeah,
sorry Lisa.
And I have them on there. I
Oh,
have
you
them.
got Lisa. Yeah, you all were on the list to contact, okay?
You really should continue with it. I'm just.
Yeah, okay, sure.
That's fine, I just was curious, because
Was there
we,
another question?
the lab had always paid for it. And then our other question was about the money for FedEx. We're paying for our own boxes. We have an account with them.
Well,
Um,
Lisa, it's Leanne.
Why don't you come up here so everybody can see?
Are you, when you say you're paying for your own boxes, I'm only talking of the ones that we pay for, our Hep C, your Zika, your, of course, Ebola, if we ever had that, your flu, your norovirus, and any enterics that you send to us, and newborn screening. Those are the ones that we'll pay for. So if those are things that you're sending, you can use the account that I'll send you an invite if you want one.
Honestly, we'll just keep it the same because we don't want to confuse it. We have each of our sites has a FedEx account. And we were paying that out of postage before and then we switched to FedEx, it's about the same cost.
Okay,
So
yeah.
to avoid confusion, I'm just gonna keep it the way it is.
Okay, so, and also, I want to let you know really quickly on the Hep C tubes, if you all have any issues on the Hep C, I know that they put it in the CCSG that every STD person coming in is having a Hep C. Please do realize that, we do limit those, and I know I talked to Northern Kentucky, we did send you some extra ones. They cost $2.68 per tube, so just be aware of that when you order, and I understand you need to have supplies, and if you have an issue with that, please contact me directly. I appreciate that.
Okay.
And Lisa, you should get the state government rate for your FedEx, so make sure your boxes aren't over like $8 a box.
They're not, it's like 6 something.
Okay, good, all right.
Okay, thanks.
And Leanne, did you happen to mention the contract rate for those boxes? I was out of the room very briefly. For us mailing in their samples.
Oh, no. If you want to do FedEx with any other of your samples, like your chlamydias or, your syphilis or anything like that, you are eligible to have the state rate as the health department. So if you have a FedEx account, you can contact FedEx directly, or you can send it to me and I can have our FedEx government rate person. I can send you all that information so you can make sure that you can sign up through that. And also, if you have a UPS account, also if you'd rather ship UPS, you can also do it through UPS and have the state rate. So either one.
Okay. Thanks to ELS Partners. I appreciate you coming over and the great information, and we'll follow up and get our homework assignments completed, and we'll send that information out to you all, okay? All right, thank you. Next, I have Shannon Bishop, and 4 of her closest friends with her. Shannon, as you all may know, is the project manager for ECW. She is with OATS, which is our Office of Administration and Technology Services, under the CHFS, are you under the umbrella? Yeah, the cabinet umbrella. And so Shannon and I spend numerous hours a week with each other on ECW. And so I invited her to come and with her team to provide an ECW update for you all. And please feel free to ask any questions of Shannon. She's all things ECW and will be able to assist you all with any questions that you might have and provide an update for us today. Thank you, Shannon, for coming in and your team. I appreciate it.
I apologize for messing up your agenda.
Nope, you're
Messed up
fine.
Joy's agenda.
You're fine.
So I'm Shannon Bishop. I'm up here in Frankfurt. I am like Joy said, the PM for the DPH EHR project, which the software is eClinicalWorks for the EHR. Right now, what we're doing is we are working on the pilot phase of the project, and since Dr. Polk has joined us as the commissioner, we've kind of changed strategy a little bit on the pilot. There's only been one pilot phase of the project. Dr. Polk wants us to make sure that that pilot is successful before moving forward with the statewide deployment. So what that means is we will have Lincoln, Bourbon, and Madison counties as pilots. We're talking about including Green River District. And I think we're leaning towards, yes, they will be included, but we gotta work out a plan because we need additional resources to train those folks. So, so that's not a done deal yet, but we're working on that as we speak, really. We're doing it today. Let's see, Lincoln, Madison, and Bourbon will be trained, end user training at EKU, the weeks of October 17th and October 24th. We're working with the pilot sites, actually we have a call with them this afternoon to kind of give them some more information. They know the dates, but there's, logistics involved because you can't close down your local health department and take everybody over to EKU to be trained. So we've got to work that stuff out. And Jessica's going to talk more about kind of what we plan. Let's see. There's 3 risks to this project. Well, let me back up. The pilot will go through, they'll go live November 1 or that week, October 30th.
October
31st. And then the pilot will end February 15th, 2017. So what we have to do is Dr. Pope wants me to come up with some criteria so that we can determine if the pilot is successful. So we, my friends here, and I'll introduce you in a minute, we will come up with that criteria. There'll be an initial assessment in December, and then a final assessment in February. Dr. Polk, all the executives will take a look at it, and then we will then begin to plan out the rest of the deployment strategy. So, and we're working on that too. So let me tell you who I got right here. I've got Jessica Price. I think some people know her. She was formerly Health Tech Solutions, but we've got her. We've got Stephanie Hudson, formerly Health Tech Solutions, but we took her too. And then we are so glad to have Deanna Saleh. She's going to be our help desk person. So we've got Jessica and Stephanie as our business analyst, who's going to help me tremendously because I needed help bad. And then Deanna's going to work on the help desk side. We've got another person, Alvin LaShore. He's going to start next week, and he's going to be our second help desk person. So we're trying to make sure that when we bring these pilots on site that we've got the support that we need when everybody goes live. And then we've got Michael Beard here. He's our ECW implementation specialist. And he helps us with all things. So let me hand it over real quick because I know everybody wants to go to lunch. Hand it over to Jessica just to talk a little bit, take a little bit deeper dive into what we're thinking about as far as the training goes. Stephanie and Jessica.
Sure. Hi everyone. I know I've spoken to you all several times before, and now that we're back again on this side of the project, so what we're thinking a little bit, Shannon mentioned a little bit about the training taking place over 2 weeks at EKU for our pilot sites. However, that 2 weeks, like Shannon also said, does not mean 2 straight weeks of training for everybody in those health departments because we realize that's completely unreasonable. So what this training will probably look like, it's likely that week 2 will pretty much mirror week 1, and the trainings will take place in 4-hour sessions. So the way that eClinical Works is set up, it really divides the health department staff into front office, clinical, and billing staff. And we realize that in some health departments there will be staff who cross over and do both front office and billing per se. So which sessions each staff member needs to attend may vary just a little bit from health department to health department. So the front office staff will likely attend 2 to 3 4-hour sessions to learn their roles in the eClinical Works system. Clinical will also attend probably 3. Billing is probably about 2. And that could vary, so don't hold me to that. But the 2 weeks allows for the health departments to send some of their staff the first week to the sessions they need to be in, some of them the second week. And whenever we have that finalized, we'll get those calendars out to make sure everybody knows when each of these sessions will be offered so that you can begin to make plans. It is likely, because we'll be pulling some of the staff, that the patient volume may decrease a little bit for those 2 weeks of training. However, there should not be a need to shut the health department down. That's what we're hoping for in those 2 weeks. Those 2 weeks also will provide us with some time towards the end of the week to sit down with any staff who feel like they might still need some extra one-on-one attention. Maybe they had to miss a day for whatever reason, or they just don't feel like they're quite as caught up as they need to be for their go live. We'll definitely take some time to sit down with those staff members at the end of the week and make sure that they're comfortable. Then the go live week, which like Shannon mentioned for these pilots will be, I think it's actually October 31st starts that week, the beginning of November pretty much. You'll have resources on site your health departments. The districts, we'll have to discuss with the health department directors exactly how that will look. We realize it may make more sense to have 3-4 people floating throughout the district, but we'll kind of discuss those specifics as we get there. The single county health departments, you'll have on-site support for your Go Live week. That means that you'll have somebody there whenever a patient comes in with something that maybe we didn't cover specifically in training and you need a little bit of help, or something goes wrong with the system that you just don't know how to troubleshoot yet. We'll make sure that you have all the resources there that you need. Post Go Live, once we're not on site anymore, it's where Deanna and Alvin and the rest of us will come into play. We'll be there for ongoing support to answer any questions that you have, especially throughout the pilot phase. We'll be working closely with the pilots to make sure that they have all of the support and the resources that they need. So, like I said, the training specifics are still being nailed down. We do know EKU will be a training site for the 2 weeks for the Madison, Lincoln, and Bourbon pilots.
And they have dual classes going on in those 2 weeks. So there's 2 sessions for 2 weeks.
Mm-hmm.
So there's 2 separate classrooms there.
So you can almost think of it as like 4 trainings kind of, over those weeks. So plenty of opportunities to make sure that your staff can get in there and get the training that they need. And they're always welcome if they feel like, and we have room, of course, if they feel like they want to come back for some of the sessions in week 2, they're welcome to do that as well. So we'll be working with the health department specifically to make sure that they have all of those details. Are there any questions about any of that?
The only other thing Jess forgot to mention, prior to the pilot phases and training, we have a pre-go live kind of checklist of things that we are going to go ahead of training and make sure that we've captured everything and that everything will be set up in the system ready for them on training, such as provider schedules, provider signatures,
Your local pharmacies.
local pharmacies that maybe aren't listed. There's just a big list of things that we're going to go ahead of time, capture, and have in the system so that when you go to training and you log in, it's going to look exactly like it would look Go Live Day.
Okay.
So that will take place too.
And as always, if you think of any questions, after this meeting or whenever, you can email any of the 3 of us, Shannon Bishop, Stephanie Hudson, Jessica Price, when we can all make sure that we get you answers as well. And Joey knows how to get a hold of all of us.
So let me say one more thing, Joy. Mike has sure. So Michael Beard had to leave because he is going on site to Bourbon today. So what I want to talk about real quick is there are 3 risks to this, that all of this could be delayed if we don't address there's 3 things that have to be resolved, I should say. One is we are working right now with a direct contract with Claim Remedy, that's the clearinghouse for billing. We've got to get the enrollment done for billing, that's key. You got to get paid. So I think that the risk is kind of like a medium level at this point, but if it drags out, that's going to be a problem. And the steering committee is aware of that risk. We also have another risk with data migration. We're working with CDP to get the files that we need. It was going to be a migration for all the demographics, patient name, address, and all that stuff. The test file is not good. The timeliness of the file, not good. So what we're doing is we're dealing with that issue, but Plan B is we're exploring the suggestion of not doing a data migration. And so what Mike is doing is he's traveled to Lincoln County and Madison this week, and then he's going to Bourbon today, as I said, because I want him to show those folks how easy it is to key in a patient, to key in the future appointments, start fresh, have good data. It's easy. And so we're just trying to sell the idea because I cannot plan this go live and not know when I'm going to get the final file, and then have these local health departments validate this data, try to fix the data. The appointments would be outdated if it's not timely. It'll be more work. So that's a big risk, and we're working through that. The third risk is the final financial interface. This is where the piece with the cost centers and the spread that we do. we've got the statement of work almost finalized. We've got a meeting tomorrow. We think that that's doable. It's a medium level risk at this point, but it has to be completed. It has to be tested before we can take anybody live. So I just wanted to talk about those 3 items and set the expectation that those balls are up in the air. And if one of them drops, then we're gonna have to reevaluate this whole thing with the training and the go live. So everybody knows about it, but I just like to be upfront with everybody, and if everybody, oh gosh, the date's changing again. I mean, there's just a lot of moving parts, and we're not gonna go live until we test everything and make sure everything works. Any questions? Okay.
Would you mind to introduce Deanna and share with her about her role
Sure,
at the help
Deanna.
desk, and because local health departments will probably get Deanna when they call.
So what Deanna is gonna be doing is she's gonna be on the help desk, or service desk support, whatever you wanna call it, along with Alvin. So she's gonna be the one that you'll get on the phone, or you'll send an email to, and she'll be that first level of support. I need my password reset. I've got a quick question on, it's kind of like a functionality, even how-to type questions. If it becomes more of more research is needed, it's more of a complex problem or whatever, then we'll escalate it to level 2, which would probably bring in Jessica, Stephanie, Michael Beard, and by the way, he had to leave, sorry. And then we would all work together to resolve that issue. If we can't, then we would open up the support ticket with ECW. And that way because we could get a million calls. I mean, not really, but in the end, so we gotta have some kind of process in place. And I think it's gonna work out well. Right now, with the dental hygienists using the system, what they're doing is, Deanna is located over at LHO over here in the CHR building. And you just open up a ticket just like you would if you're not an ECW user. And then if it's ECW, they give it to Deanna to work, and then it goes through the same process.
I just wanted to let folks know that the ECW help desk functionality was in place and moving forward, and you'd be there to help facilitate. Deanna and Alvin would be there to help facilitate that logging in process and passwords
And at first it can be, tell me how to get somewhere.
Right.
We did see those questions with dental. And as they used the system more and more, it became true, I have an issue, not I can't remember how, but it's both things.
Yeah.
It's all those.
Yeah, we just want to create that centralized location so that we can address we need to maintain the system ourselves here at DPH. So we want to have the knowledge before we send it over to support, clinical work support, and then deal with it. So we've got a process in place. Thank you, Joy. Sorry I messed up your agenda.
You have that next time.
Thanks, everybody.
All right, thank you. I see a couple of directors out in the field. Does anyone have any questions for Shannon before she leaves, or any of the nurse leaders or IT folks that may be participating?
Well, that means we covered
Okay.
everything.
All right, thank you all.
We were very
Appreciate
thorough.
it.
How are you doing?
Next, we're going to have Gina Reed present, actually from Hart County. Gina, as you all may know, on the western part of the state, she serves as the QA coordinator for the Kentucky Women's Cancer Screening Program, as well as the Family Planning Program. And so the medication policy or plan is a part of the QA visit tool. And so if you're not aware of that, we wanted to make sure that you were aware of that, and that there were some slight changes that were made to the administrative reference this year that will impact clinical services and policies as far as obtaining your pharmacist's signature on your medication plan. And so I've asked Gina to provide an overview and update of the medication plan and talk about the components of that plan, and just to make sure that everybody's up to speed on that. And that is a requirement, per statute for all local health departments to have a medication plan in place as a part of your policy. So we wanted to provide that technical assistance and guidelines to you all today. At the same time, and Gina, before you start, I'd like to introduce Kim Anderson. Kim, do you want to come up, or yes, no? Okay. Kim's shaking her head no. I'm springing it on her, so I apologize, Kim. Just wanted to introduce Kim Anderson, who is our new QA/QI nurse consultant for the eastern part of the state. And Kim is replacing Debbie Donovan, who you all know transferred to Bourbon County several months ago. Kim is doing an excellent job. She's completed every module, every training known to mankind. She shadowed Gina several times, several visits, and has started the site visits on her own independently, and has already demonstrated what a valuable resource she is to our division and to local health departments. So I wanted to let you all know, if you haven't met Kim yet, here she is, and and if she emails you or calls you, you'll know that she's contacting you about your women's health site QA review. You want to say anything?
No, I look forward to working with everyone.
Yeah, okay. All right, thanks, Kim. Okay, Gina, are you there?
I am here.
Okay, good to have you this morning. Let me pull up your
Thank you.
Let me pull up your presentation, and we'll get you going here, okay?
Okay.
Let me just get logged in here. Okay, you can advance the slides for Gina? Okay. Well, take it away, Gina, and we can hear you just fine. Can everybody hear Gina out there in the field?
Good morning.
Yeah, okay. Thank you.
As Joy said, we wanted to kind of go over this. There was a few changes in the AR that went into effect August the 1st. And we felt like too would be a good time for a review for some of you, and then the other one, there are several new nurses out there in the field that have not probably heard this or seen this information before. So with that being said, I also had several attachments to the PowerPoint, but I gave you the administrative reference, and it's in the medical records section, pages 40 through 44, and that's the guidelines for local health departments for your medication plans. And then we gave a sample medication plan, and I gave you the law, the statute, as Joy said. I always like to have something in black and white to see what's telling me the reason I need to do this. And then I gave a few sample medication logs on there. And I know a lot of you already have things in place for your medications, but I thought this would be a good time to review what you've got. You may want to change it or update it, or and also a good time to update your medication plan. So we'll go to the next slide. Of course, the law states that every health department shall have a medication plan or policy in place. And like I said, I've got your copy of the law there, the statute. It should be signed by and developed in consultation with the local health department board pharmacist or designee. And I know some of you may not have a pharmacist on your board. I think most of you do, especially in the districts. If not, you may have some kind of a collaborative agreement with a pharmacist there in your community or whatever, but it should be signed by the pharmacist. It also should be approved by the local board of health. And one of the changes that came up for this year is it should be reviewed and signed annually. So you may want to, I don't know, put this maybe with your signed protocols with your CCSG or something to know that it should be signed and reviewed and signed annually. And so that is a change. It should include, purchasing, storage, inventory, dispensing, and reporting of medication errors. And we'll go into that a little bit more as we go through here. It should be consistent with DPH and the Board of Pharmacy and any other relevant laws and guidelines such as like KVN. And then only additional in-house medications specific to the LHD must be included in the policy. So medications that are listed throughout the CCSG need only be referenced in the policy as all medications listed in the CCSG. But then if you give other meds that are not in the CCSG in-house at your health department, then you would need specific orders, or that would need to be added to your medication policy. And this includes all family planning methods, STD and TB meds. Local health departments prescribing drugs that are not in the CCSG assume the responsibility under local authority or individual licenses. So that should be under physicians, might be your medical director that you have sign off on those other drugs that you may be given in-house, or the APRN. If the local health department prescribing drugs are added to a local health department formulary, these medications again shall be included without specific endorsement by or liability to CHF or DPH. So the only ones that are through DPH are the ones that are in the CCSG. Local health departments assume responsibility for conforming to the pharmacy and other relevant statutes if you provide other medications other than in the CCSG. I'm going to go through a few of these definitions just because they're very relevant when it comes to this law. And many of you may remember several years ago something came up that there were some issues with the pharmacy board that wanted health departments to stop issuing the birth control methods. They felt like that nurses were dispensing, and that dispensing fell under the pharmacist role. So that is what brought about this law initially. You can see at the bottom that it went into effect July 15th, 2002. So, but the prescription means authority. Can you go back to one? Okay, thank you. Prescription means authority to obtain a prescription drug, and authorization can be given to the pharmacist by a piece of paper, a phone call, a fax, or electronic scan. An MD, a PA, or an APRN within their scope of licensed practice and collaborative agreement, if it's applicable, may authorize a prescription. And prescriptions may be provided to patients with public or private insurance. Under ACA guidelines, most contraceptives are covered without cost sharing for the patient. Prescriptions may be provided to clients without insurance in the following instances, because normally you're going to keep, stock for patients that do not have insurance in-house in your health departments, but you can provide prescriptions for those patients. If the patient specifically requests a prescription for a method that's not available in the health department, or if patient specifically requests a prescription for a method temporarily out of stock, or if the local health department is unable to obtain a particular method because the health department's met the manufacturer's purchasing quota. The next definition is dispense, and dispense means to give a patient a drug to consume or use later. So this is where a lot of our birth control methods fall into, like for
the pills and that kind of thing. Dispensing is legal for RNs and APRNs only in health departments following CCSG guidelines and health department medication policies. So, and that is stated in that statute. And that KRS 314.011, which I gave you a copy, or no, I didn't give you a copy of this one. That has the provision for dispensing, which is an exception for local health departments. So only health departments can dispense these medications. This law gave special approval. And then per the Board of Pharmacy, an RN, ARN or APRN can dispense a medication from a multi-dose bottle to be sent home with the patient to be taken later. And that is part of the dispensing that we're talking about. And that sometimes that is like the STD meds you may be doing that with, where you're counting out so many of the antibiotics. The drug must be packaged, labeled, and recorded according to pharmacy law. And pharmacy labeling is an FDA requirement, and that law is not found in Kentucky law documents. Requirements for proper labeling of medications to be dispensed include the patient's name and date, name of provider prescribing the medication, name of medication being dispensed, the specific instructions to the patient for proper use, quantity of pills or medication being dispensed, and name and telephone number of the facility. And if you're giving 13 packs of pills or 12 packs of pills, all of that should be on each pack or each dose of whatever you're giving to that patient. It should be, a lot of health departments use labels and have all that information on it, or write in certain parts of it that each pack should be, in case a pack got lost or whatever, it would have the dosage and everything on there. Dispensing of sample drugs within their scope of practice is legal only for APRNs. And I don't know that many of you all have sample drugs in the health departments, but only APRNs would be able to do that. And then the definitions for administer means to put a drug into a patient's body. This can occur by giving an injection, oral medication, applying a cream or ointment, or use of an inhaler. And I think also probably instilling eye drops, prescription eye drops would probably fall under that too. But administration of a single dose is legal for LPNs, RNs, and APRNs upon authorization of an MD or APRN. That being said, most of the time in the health departments, with like the immunizations, administering that single dose of medicine, that's where your administration falls under. And I know there are still some LPNs out in the health departments working, so that would be covered there for them. To deliver means to hand over a previously dispensed drug. So LPNs and unlicensed personnel may deliver medications that have been properly dispensed. So that would have been already dispensed or by the RN or the APRN, then the LPN or unlicensed personnel could deliver that medication. It is recommended that this be done in the health department under the delegated authority of an APRN or RN. And you could contact the TB Prevention Control Program for the DOT medication guidelines, because I know that there are unlicensed personnel out there. I think some still do in the DOT. You want to assure that other brands or generic forms of medications contain identical amounts of the same active drug in the same dosage form. So that would be something to look at if you're ordering something in generic. Doses may be adjusted based on weight and age. Before crushing or giving any medication mixed with food, check with the prescribing clinician for instructions. Each local health department should include in their internal medication plan who is responsible for the cost of a prescription when given to an uninsured patient. So So that's just something to think about to add into your medication plan. We've attached a sample medication plan that has a lot of the requirements in there. That can be used, you can take it and tweak it and make it your own as far as your in-house policy or plan. There may be things you may want to add. Local health departments will only prescribe medications listed in the CCSG. Any additional in-house medications specific to the local health department should be listed in the medication plan. We talked about that a few minutes ago. Generic equivalent of these medications may be prescribed when available. Prescriptions for these medications will be written by a MD, PA, or APRN. Again, if the APRN, if it's applicable for them to have a collaborative agreement on file. Prescriptions may be obtained in writing or per telephone order. I did also, one of your attachments that I gave you was the telephone order and the actual instructions on the telephone order, and that can be found in the CCSG online under the forms section. But basically, anytime that you're going to do a verbal or telephone order and use that form, you would always want to keep a copy in the chart until you get the original signed copy back to go in the chart. So, the nurse administrator will be responsible for purchasing all medications, and this could be the director of nursing for a district. This could be, if you're a single county, the nurse supervisor. But as far, and it actually spells this out, I think in that law, that, as far as purchasing the medications, you may be working directly with your purchasing agent, but still, as far as the nurse supervisor or DON, you would be responsible ultimately for those prescription medications. Medications will be stored in a secure cabinet or room with appropriate temperatures as recommended by the manufacturer. Refrigerators storing medications will have temperatures monitored daily, and I know some of you, I think it may even be a little bit more strict for the immunization program. I think they may have to monitor twice a day, I'm not sure now. Monthly inventory will be done on all medications in the health department. And I added a sample monthly inventory log to one of the handouts, and I kind of wanted to stop right here for a minute and kind of go over this for a little bit, because when we're out there doing the clinical walkthrough for the QA, we're looking at where you've done your medication, your daily logs, like where you sign out for your daily logs. But then we also want to make sure that you are doing the monthly inventory. And so monthly inventory, the handout that I gave you, it's on Excel. There it is. It's on Excel, and you can change the headings across the top, or you can change the headings down the side. But basically, a couple things, you always want to go with your balance forward, and if you've received any medication in, like you've had any new orders come in. One of the things I wanted to discuss was sometimes a patient will come in and return some medication. You may have given them 3 packs of pills and they can't take them, and they come back in and say, I can't take these pills. If the patient returns medication, those are going to have to be disposed of. Of course, you can't give those out to anyone else at that time, but you're going to have to show account for any medication that comes in or out of the health department. So that's on there, and then how many that have been dispensed for that month. And then if you've got any expired medication, you also need an internal policy of how you're going to dispose of expired medications. Now, basically for expired medications, you could put them in biohazard containers, but you would need to show that that's come out of your inventory. And you may even want to have a separate log where you disposed of expired medications or medications that's been returned by the patient. And if you do, you need to show that they've been disposed of, and then the RN needs to sign off on that, and it would be good to even have a witness, like a second person that shows, you know, that those medications, I know I'm used to, a lot of times the STD medications would expire, and so you need to have something, that would probably be something good to add to your medication policy or plan in-house. And then if you're a district, you may have, where that you dispense to another site, like internally from one county to another, and then you're gonna show your balance on hand. And then if your balance on hand, then it should be your correct balance, but it may not be. You may be off, you may be short or over, and it shows that there. And any time that you do not balance on your monthly inventory, then you would want to, at that time, you would need to let your supervisor, notify your supervisor, and then you need to do an incident report. One way to go back and look for medications if you're off a certain medication is to look at your daily sign-out log for that medication, and you might have to go back and pull PIFs, and it may have not even got logged in on the daily log. That may be why you're off. So you could go back and pull PIFs and look and see, maybe you gave medications to somebody that didn't get logged in that day. So especially if you have several nurses that are giving out and signing out, sometimes it gets busy and an error is made. So the next one that I wanted to go to is the daily log. And the daily log basically is your daily sign-out log. And I know most of you have this available, but here's just a blank one. And remember, these are just samples. You don't have to use these if you've already got things that you're using in-house that are good for you and are working. But I know a lot of people have asked for samples of things, but you would always want to have the medication name, and then you would want the date, the patient label, or at least some kind of patient identification, so like the name or date of birth or social. Because I know if you just put the name, there's several health departments that have patients that have the same name, so you've got to have some kind of ID for that patient. The quantity of medication that you're giving, the lot number, the expiration date, and the initial of the RN or nurse that signed the medication out. So with that being said, we'll move on to the next slide now. Okay.
Go to your slideshow. There you go. And then just say from current slide, then the second one.
Okay. Let's see. I think
Is that the right one, Gina?
no, I think we're back. I think we're back a couple there.
Okay. One more?
Go back one more. And then go back one more. Okay. So in the event that you did not balance, then you would want to let the supervisor or director of nursing know and an incident report completed. And then we're going to talk a little bit about the emergency resuscitation drugs, supplies, and equipment. They should be kept available in a location that's centrally located in case you needed to grab it quickly. The emergency drugs will be checked monthly and recorded on an inventory list that's kept with the supplies with a copy of the current CCSG emergency protocols. And I did not make you a copy of the emergency protocols, but just as long as you keep that signed current copy in your kits. I did give you you don't have to go back to this one, but I did give you also a sample copy of an emergency equipment supply medications monthly checklist. And this one is a good one because it has the nurse's initials and the date reviewed at the bottom. It also keeps up with your emergency drugs as far as their expiration dates. So you can kind of look at it as a glance monthly. when you're doing the checklist, to see, you know, if your emergency drugs are getting ready to expire. So, and I want to thank Bear River. Julia actually gave us permission to use these samples of forms. I also have some other forms if you all would like to see them. Lincoln Trail, Glenda shared theirs with me, and also Abby at Green River. So if you would like to see, if you're updating your internal logs or you want to see other ones, I do have other ones available also. Your monthly emergency checklist, again, I provided a sample. Those should be checked by an RN. Medications listed in the CCSG will be dispensed by or administered by RNs, APRNs, or physicians, PAs, or physicians. Medications must be packaged, labeled, and recorded according to pharmacy law. Before administration or dispensing medications, patients will be assessed for contraindications, allergies, and side effects. Patients will be educated for appropriate use of dispensed medications and assessed for understanding and compliance. And that is kind of where our FP forms that we use for education and counseling for the family planning methods come into play. And then you would also want to make sure, you know, that you've assessed that patient for understanding and compliance. And it's good to even document, you know, that patient voices the understanding when you give them the medications. Prescribed over-the-counter medications that are not listed in the CCSG may be administered by RNs in the school setting or per the school health policy. I know most of you have internal school health policies for your medications that they give in the schools. Prescribed medications must be sent to school in the original label container, and the label shall include the name, address, pharmacy, name of the patient, name of the prescribing practitioner, date the prescription was dispensed, expiration date of the medication, name of the medication, dosage and strength of the medication, and route of administration and frequency of medication. So again, like I said, that's, I'm sure, in your school health policy or school nurse policy. Next. Care will be taken to assure medications are administered per right route, right dose, right medication, right time, and right patient. Of course, that's the 5 rights that I think you learned in basic nursing school. So that's just kind of a review on that. Medication errors will be reported to the director of nursing or the nursing supervisor as soon as the error is discovered, and the patient will be assessed for side effects and medical referral made if necessary. And then after all that is done, and you're sure that the patient is taken care of, then an incident report should be completed. Medications may be delivered by unlicensed personnel after being properly dispensed by appropriate personnel, which we talked about the being dispensed. These clients must be first assessed and educated about the proper use of the medication by licensed staff, and then all medication must be documented in the patient's record. And again, for any questions with the TB or DOT, you would want to contact the TB program. Medication that is refused or omitted must be documented also. In the event the patient cannot swallow a tablet or capsule, the prescribing practitioner or the board pharmacy will be consulted before brushing or giving any medication with food. Medications or devices prescribed for the purpose of causing abortion will not be dispensed, and that is in that KRS 311.720. Board pharmacists may be consulted at any time there is a question concerning medication, information for patient education, or such as drug interactions. In accordance with the KRS 212.275, in the event the health department consults with a pharmacist license pursuant to KRS 315.030, document the consultation
Are there any questions for Gina from the field or here in the room? Thanks for that great comprehensive overview, Gina. You all may have noticed that Gina attached several documents for you all as far as sample logs and supporting documentation. And so as she mentioned, if you're do a good scrub down for your medication plan policies, please feel free to use those samples or contact Gina for the other samples that she may have. Certainly she's an excellent resource, having been a director of nursing in a large local health department district in her past, and so she's a valuable asset to our team. Are there any questions? Yes, go ahead.
Sorry, we do have a question.
Yes, ma'am.
On the first page, like on the third slide, it says signed by a board pharmacist or designee.
Right.
And then on the last slide, it said pharmacist, medical director, and LHD director. I'm just curious who the designee could be.
It could be, if you don't have a board pharmacist, I don't know, or not, but it could be, I've seen some health departments that don't have a board pharmacist. They have a collaborative agreement with the pharmacist locally that they collaborate with, and that pharmacist signs their medication policy.
Okay.
Any other questions? Okay. Thank you so much, Jean. I appreciate it again.
Thank you.
Okay. And closing out today's ITV, I'll invite Shelley M. Wood to come forward to provide a Zika update. We're running a few minutes late, and I apologize for that. We've had a lot of good information today, so Shelley, feel free to go ahead and present the information that you have, and certainly if you all need to break away to go to clinic or have other obligations, this ITV will be archived, and you can watch the whole ITV in its entirety, or just tune in for the Zika update if you need to leave now. And I'll go ahead and get this off of here for you, Shelley. Okay, there you go. And I'll put you up on the screen. You got her? Okay, thank you.
Okay, Joey asked me just to provide a quick update, and I'll have a PowerPoint, and I'm just gonna hit a couple of highlights just to let you know. We've done several of the Zika in-depth presentations. And so I'll just start out, but in the United States, travel-associated Zika, confirmed Zika cases is growing as we expected. They continue to be on the rise. The good news is there's only one place right now with local transmission that we know of. That's in Florida. Florida was expected to be the first place with local transmission, and they are. This isn't really anything out of the ordinary, as we were expecting. You know, Florida has had local transmission of chikungunya, they've had local transmission of dengue, and so for, you know, it's the same types of mosquitoes that carry those diseases. They haven't had an outbreak throughout the entire state. It's usually in little pockets and pods and pools of mosquitoes. So currently in Miami area that you hear about, that is in the Wynwood neighborhood. They have marked off 150 meters, and those where the pools are. And you've heard me say it before, you've heard Dr. Brown say it before, who's the entomologist, and he's world renowned. He says if the Aedes aegypti mosquito is born in your backyard, it dies in your backyard. So again, they don't have a very long fly radius, and for that reason, that's why there's the 150 meters. It's about 1 mile square area, or 1 square mile area is what I should say. And that is the area that we're concerned with. So just visits with the Miami, really not a concern. If it's near the Wynwood neighborhood, which is a huge tourist attraction there because it has the art walk, and apparently it has walls throughout the town. And Wynwood neighborhood is not like, well, I was traveling and I was all over and I don't really know where I was. Now, you know, if you've been to Wynwood neighborhood, you like enter Wynwood neighborhood and you leave Wynwood neighborhood. Like I said, it's a big tourist attraction because of the art walk that's there. So we have tested a few that have visited that area, but as of right now, we're all at 0 from the Wynwood area. Kentucky does view Wynwood. We are treating that just like we do the Zika affected areas. So it's going to be under the same guidelines as we would for somebody that's traveling from Mexico or other South American country. As of August the 10th, CDC reports nearly 2,000 travel-associated cases, and that's throughout the continental United States. So about 2,000 cases, and that includes 22 that they suspect of being sexually transmitted. Remember, sexual transmission goes as travel-associated if it occurred when they had sex with unprotected sexual intercourse with a traveler to a Zika-affected area. So of those nearly 2,000, it's not quite 2,000. I rounded up. It's like 1,970, and that's as of August the 10th. So that includes 22 sexual transmissions, 1 laboratory-acquired case, and 6 locally acquired cases. Which, you know, I've heard that number's gone up, but I haven't seen it in writing from the CDC. So therefore, I'm reporting what CDC has. I'd heard that 14 people had actually tested positive in the Wynwood area. And so that's those 6, or those initial 6, as of August the 10th. In Kentucky, as of yesterday, our numbers are updated as of yesterday, we report 20 confirmed cases of Zika, and all of ours are travel associated. We have no cases of local transmission. From there, we'll move right into the mosquito surveillance, because that's how you know when there's local transmission. And our mosquito surveillance in Kentucky, the positive note about Zika is it's really provided the state a great opportunity to perform increased mosquito surveillance. And that's a good thing because, like I said, there's other illnesses, viruses that are caused from mosquitoes. We know that West Nile is caused from a mosquito-borne illness, chikungunya, dengue. So there's other cases besides just Zika, but what Zika did, because of the sexual transmission of it, it really, and the microcephaly, you know, that's associated with the infants, it really brought the public health threat and increased it, so therefore funding came in with that, so that we can try to really cut down. So we do the vector control and the surveillance. So it's both pieces, and it goes hand in hand, and it goes hand in hand with the human surveillance as well. So therefore, we've had the opportunity to increase our mosquito surveillance and our vector control in Kentucky. And since early part of June, Kentucky has continued semi-weekly surveillance at several sites across the state, in the western part of the state, central part of the state, and eastern part of the state. They've been doing that a couple semi-weekly. Right now, we've had identified, not me, but the entomologist and environmentalists have identified one Aedes aegypti. And so we've collected nearly 30,000 individual mosquitoes, and all of those have been specified, or specification, or whatever they call it. So all of those have been identified, and of those, we have one Aedes aegypti. So as we suspected, that number is even lower than what we had previously estimated it being 1 in 5,000 mosquitoes being Aedes aegypti. And as you know, Aedes aegypti is the known competent vector. That's the one, that mosquito is the one that has always been known to carry Zika virus, even from, the time it crossed from Africa. So that's that. Kentucky does have a large number of Aedes species, but not the Aedes aegypti. So what we usually see is the Aedes albopictus. It has not been an important vector in Zika at this time, and that's anywhere. So it just really has not been an important vector currently. It doesn't mean that it can't cross those species, because in our in-depth presentation we learned that initially when it was in the Aedes africanus, it had switched into a different Aedes aegypti species, and so it's hopped species several times. But right now, it has not played an important vector role. And then experts anticipate that the mosquito populations are right now currently in their peak, and from this point on, they should slowly start to taper off for the rest of the season. Go right into the Zika positives. When a person is identified as being Zika positive, communities are handling the responses at a local level. And that's with guidance from the KDPH in collaboration with Department of Agriculture. Us, and then Fish and Wildlife has had to be brought in, a couple of times too. So it's really a collaborative effort, and that's been the great thing about the Zika. So just like Ebola brought us all together, the healthcare, the hospitals, everyone else, Department for Public Health Preparedness, it's the same thing with Zika. It's really brought a lot of collaboration together, because it would be overwhelming for one and incomplete for the other, if they try to isolate it and work in the towers or the silos, is like what I like to say. When a case tests positive for Zika and the patient is still in the stage that's considered to be viremic, meaning that person can spread that illness to a mosquito if they get bitten by a local mosquito, then we're being very proactive to stop the spread of Zika by means of education. And when I say that, we educate them regarding the sexual recommendations. I don't really have to repeat that here, but I can't pass up the opportunity. So if a male traveler travels from a Zika affected area and he develops symptoms within 2 weeks of that travel date or during the travel date, then his recommendation by the CDC is to use condoms with every sexual encounter for 6 months. If they return and they do not have any symptoms, then it's going to be for a period of eight weeks, so 2 months. We also educate enhanced mosquito precautions, mosquito control, and then regarding blood donations. Part of that mosquito precautions is using your insect repellent for 3 weeks after you return. Part of the mosquito control is they actually get an environmental assessment. So the health department will send someone out and do an environmental assessment of the home. This is when they're considered to be viremic, and recommend removal of tires and standing waters, etc. Vector control, if needed, that will consist of spraying if that's needed, and this can be in conjunction with the local strike team, Department of Agriculture, or Fish and Wildlife, and then they may use larvicide if that is also needed. Also note that the Department of Agriculture informed us yesterday that last year they had 600 nuisance calls, because they address every nuisance call that they get for mosquitoes, and this year they've had over 2,400. And all of those calls have been addressed. And again, they are collaborating with the local health department so that they're not spending their resources of their 8 guys to go out and, go to a county out in eastern Kentucky. They'll call now the local health department in eastern Kentucky and let them go out and do the assessment part. And then the local level says, yeah, this is a problem and we're not going to be able to to spray or whatever, so then the Department of Ag will go spray that, but they are collaborating with that. And they ensure that the spraying is very safe. It is very minute amount. It's like less than an ounce that does an acre or something. It's kind of crazy, the small amount that it takes, and it's not harmful to humans. And there was a ton of research that had gone into the spraying as well to make sure that they're using the safest. And then Zika testing, I've given many presentations including the process of testing. Here I just want to provide a quick update on the testing. The commercial labs now offer IgM and PCR testing, and this is brand new. I think I saw a first specimen for an IgM like the 15th of August, which was the beginning of this week. So you got to caution that, and the only reason I'm cautioning that is because there's lots of false positives. Lots of false positives. IgMs can trigger false positive when they're sick with another illness, when they've had a recent vaccination. I mean, there's lots of reasons for the false positives, and I think they're probably even going to be more than that. The only reason I say that is because we had recently tested 2 people that kind of didn't go through the state approval, and anyways, they ended up testing, and they had no risk factors whatsoever, and they both were triggered positive IgM for Zika. And you know, that's not typical. So there are lots and lots of false positives. When they were retested, of course, then they were negative, and they redrew a separate specimen even, and they were still negative. So there's lots of false positives, as it is with a lot of IgMs. So, and there's no confirmatory testing done through the commercial laboratories. So that's going to be a little bit of a problem for us. If you have a pregnant person with a positive IgM, if we can't get a commercial lab to go ahead and send that to CDC for the confirmatory testing, I think we're going to have to reach out and probably retest them through the state to make sure that it is Zika, because it makes a big difference if we are fooling with a confirmed positive when someone is pregnant, so to know how close we need to monitor the infant. And the last thing, the update is U.S. Zika Pregnancy Registry. We're still participating in that registry, and as of August the 4th, there were 510 cases in the continental United States and 521 cases in the United States territories. So that's where we are on that. I'll close it down unless somebody has any questions. No questions? Thanks, guys.
Thanks, Shelley, for your expertise and serving as our subject matter expert on Zika at DPH. So that will end our ITV today. We're about 10 minutes over, so I do apologize for that. The next ITV will be October 20th. I've got that on your agenda, so go ahead if you haven't already marked your calendar. We'll see you in October, and have a great day, and thanks again for all that you all do for public health. Bye-bye.